Thank you. So today's program is a special one because it is a joint collaboration between Pakistan Endocrine Society and Society of Peds Endocrinology and Diabetes of Pakistan. And the topic is also very interesting and unique: puberty and pubertal disorders. We started off with two webinars. The first webinar was on physiology of male and female reproductive system. Second webinar was an overview of normal puberty and relevant embryology and genetics. So now we are concluding this with a full day symposium with pubertal disorders. So without further ado, let's start the program. And let me first introduce you to our panelists. Our first panelist is Professor Dr. Jamal Raza. He is the president of Society of Peds Endocrinology and Diabetes of Pakistan and director of National Institute of Child Health. Dr. Jamal Raza is a well-known pediatrician and neonatologist at Karachi, and he has a vast amount of experience ranging over 28 years in his line of work. Thank you, sir, for joining us today. Sir, please. Our second panelist is Professor Dr. Khadija Nuzhat Humayun. She is a professor and consultant pediatric endocrinologist at Aga Khan University Hospital. She initiated first structural fellowship program in peds endocrinology at Aga Khan Hospital and has been instrumental in getting this specialty recognized by CPSP. She has put a lot of effort in organizing this program. Thank you, ma'am. Our third panelist is Professor Dr. Mohsina Ibrahim. She is practicing Peds Endocrinology and Diabetes Clinic in one of the largest public sector hospital of Karachi, NICH. She has more than 20 years of experience in her field and more than 50 publications in her credit. Our fourth panelist is Dr. Zaman Sheikh. He is a professor of medicine and head of department at Sir Syed Medical College and director of Sir Syed Institute of Diabetes and Endocrinology. He is a renowned endocrinologist in Karachi and has a vast experience in managing endocrine disorders. Thank you all for joining us today. So let's start with our first talk. The topic is small penile size in boys, and for which I would like to invite Professor Dr. Jamal Raza on stage.
Assalamu alaikum. Thank you. Bismillahirrahmanirrahim. Thank you very much for this opportunity. I think I'm the most appropriate person to start this symposium. And if you ask me why, then I'll tell you that I am one of the founder members of Pakistan Endocrine Society. And I'm also the founder member and currently president of Pediatric Endocrine Society. So I think because this session is a combined session between PES and SPED, so that gives me a pleasure of being here as the representation of both the scientific organization, and I'm very proud that I've been associated. Thank you. Currently, I'm wearing too many hats, actually. Sorry, my introduction said NICH. Unfortunately, I'm now retired from NICH and I'm heading another organization. So that's Sindh Institute of Child Health and Neonatology. So I've put all the logos here so that I don't bother you with these logos every time. So they are only there on the first slide. So my topic for today is I don't know, what did it say, micro penis or small, but I've chosen a slightly catchy title, that is small packages and big questions. So let's see what we can understand and what are the worries, thank you very much, that are associated with the penile size. Thank you. So I'll try and keep it simple. It's a slightly complex topic, like all scientific topics, but I'll try and keep it as simple as possible for you to understand what happens in your day-to-day life and how do you approach when you see a child from different ages, because they can present to you during infancy, at birth, later on in the childhood, pre-adolescent, adolescent, they can come to you anytime. So obviously, there are slightly different challenges each time that you see them, and there's a little bit of modification that you need to do with your approach to how you treat them or how you investigate them. So let's start with the fetal androgens, because how does the process start? We have to go a little bit into the background. As somewhere around the 8th week of gestation, the placental HCG is the one which stimulates the developing testes to produce the testosterone by binding the LH receptors. And then by about 14 weeks of gestation, the fetal HPG axis becomes active, and the testo production is now under the control of fetal LH. And then the penile growth primarily depends on in the first trimester on the fetal gonadotropins, and then of course the testosterone gets converted into DHT, which is the main hormone or main product of how it converts the primordial genitalia into the masculine or the male or the boyish genitalia. And of course, you need the androgen receptors to be active to be able to do all that. Again, very old thing, but whenever you start talking about puberty, somehow you always have to go through this again. So I've just put this for you to kind of recap. We'll obviously be looking into this androgen pathway. So it starts off with the cholesterol and then the pregnenolone converting into 17-hydroxy with the enzyme 17-alpha hydroxylase. Further conversion requires the 17-20 lyase, and the DHEase dehydroepiandrosterone then gets converted here. You need a 3-beta HSD, then the testosterone, and subsequently the dihydrotestosterone with the enzymes in between, 5-alpha reductase and 17-beta. Just a recap of how the androgen pathway is active. And what does this androgen pathway do? Again, it's a very simplified diagram just for the kind of recapping the whole thing, that the testosterone goes into the Sertoli cell and the Leydig cell. And then the testosterone gets converted, as we have seen, into the DHT. The DHT is the one which is primarily responsible for conversion of the primordial genital. From the genital tubercle, it produces the glands. From the urogenital sinuses, the penile urethra, and the urogenital sinuses then converts into the penile shaft. And of course, the labioscrotal swelling then develops into the scrotum. So when you see the newborn or an infant with this small penile size, how do you take care of them, or what should you be thinking about? I think one important thing that before we go to the evaluation is that we keep that in mind, that they go through a phase which is called a mini puberty. The duration is somewhere around 1 to 6 months. Sometimes the girls, it's a little longer, up to 2 years even. You see, they behave just like puberty, where there is a rise in the FSH, and the testosterone. There's a little bit of penile growth, the Sertoli cells grow, the spermatogenesis growth, and then there are a number of other functions that are generally associated with mini puberty, resulting from body composition, cognitive function, and even the language organization. So it's a very strange phase which people still are not very clear as to how does this happen and what's the whole significance. Well, we know it happens. And then there's a quiescent period of childhood where nothing is happening in terms of the puberty. And then, of course, you go into the pubertal phase and then into the adulthood. So it's important to realize that this phase is there. So when you are evaluating this child or a newborn, sorry, or infant, then of course the usual thing is when you talk about the consanguinity, you even talk about the birth history, because some of the the maternal virilization can point towards placental aromatase deficiency and all. And even the low birth weight incidence is higher in some of the endocrine DSD disorders. And then the family history of micropenis, if there is one, and osmi, of course, is relating it to the Kalman syndrome. Prolonged neonatal jaundice is pointing towards something like a thyroid involvement and, of course, the pituitary involvement. And then others like hypoglycemia, if there's been in episodes in the early age, then it's pointing towards the growth hormone deficiency, maybe your cortisol, and again, pointing towards the multiple pituitary hormone deficiency. You look for syndromic features, you look for high arch palate, and then you examine the genitalia, and then, of course, the examination of the genitalia is comprehensive, looking at the size, location of the gonads, fusion of the labioscrotal fold, location of the urethral meatus. And nowadays there are talks about the anogenital distance, and we'll talk about it in a minute. So how do you differentiate it from ambiguous genitalia? There is simplified definition. I mean, there are a number of definitions there. No, that's not an easy thing to say. When does the micropenis or the small, sorry, I shouldn't use the word micropenis because we'll talk about it. But when does the small penile size actually refers as ambiguous genitalia? And this is one of the definition that was there. And so it's a very vague and not very constructive, but that is a gray area. So it says that it's generally accepted that when you need investigation, when the appearance of genitalia is so ambiguous that you can't do the clear sex assignment at birth. Well, you can argue with this not being a complete definition, but still. So the more ambiguity you get into the genitalia, you more associated things you get, like the cryptorchidism, like the hypospadias. You tilt towards more this being a DST than a small penile size, and probably will need more investigation in terms of the DST. There has been an external masculinization score, which started in about 2008. It takes it into, this is like the score. So it has a scoring system. Overall, the score is about 12. So the scoring system is between the labioscrotal fold 0 to 3 and 0 to 3 into the penile size. And again, urethral meatus and the location of the gonad. So this score is about 12, and it's a pretty robust, although seems very simple. There's been a study which says that it was done in like 430 odd infants born at term, and when the EMS was applied to them, almost 99.9% had a score of 90%, 99% had a score of 12 or 11, and only 1 out of 428 had a score which was less than 11. And it said that if it's less than 11, then you may think about investigating these babies or newborns. There's been a little recent modification in this EMS score, and it is called external genitalia score, which is published in 2020. And in addition to the previous one, it has been measuring the anogenital distance. So from the anus till the root of the genitalia, so it's an upper and a lower anogenital distance. And the measurement, along with the other things like the urethral meatus, the gonadal position, and the labioscrotal fold, it is arguably said to be a little more accurate and than the EMS that I mentioned. किधर चला गया भाई Skype पे? Sorry. Stuck हो गया. Sorry. Can we do something about it? आप यहाँ से चेंज कर सकते हैं स्लाइड. अच्छा सॉरी इधर से हो जाएगी शायद. So anyways, so आ गया. And then there's been a older Prada score which has been there for a very long time, and this was initially designed primarily for the CAH, where you have a Prada scale of 1 to 5, and the genitalia is differentiated from a typical male to a typical female, and things in between. That's still being used, is still applicable and useful. So it's just a matter of getting yourself familiar with Prada or EMS or whatever score that you want to use. So now we come to the micropenis, which actually is what is micropenis, or the small penile size. So the criteria is that if you measure the dorsal length and it's at least 2.5 is standard deviation is smaller than the mean, then only it is called a micropenis. Not every small looking penis would be called as micropenis, and you have to fulfill the criteria to call it micropenis. So the stretched penile length that has been used, it said if in infants it's less than 1.9, then it's termed as micropenis, and adults, of course, their sizes are there, and there is a whole range, and I'll show you the chart. They're generally recognized at birth, but they can present you at any time. And generally, the term micropenis alone is only applied when the rest of the things are in order. For example, I'll tell you later on that microphallus is used when you have some degree of hypospadias along with micropenis. So there are also some reports that, some formulas have also been described or designed to elaborate the term micropenis. It's very important as to know how to measure the stretched penile length, because as the word says, it's the stretched penile length. So you have to completely, fully stretch, press your whatever your scale you're measuring against the pubic tubercle, and then only from tip to one end to the other, you do the measurement, and then only you can say, talk about the sizes of the penile length. And if we talk about infants, then this is the chart for the normal stretched penile length. So you have the mean, you have the standard deviation, and this is the -2 standard deviation that we talk about. Starting from the pretermers, it goes, of course, into the different age. And these are different penile sizes, lengths from different countries, actually. So you have from number of studies from India, and then Korea, and then Japan, and Brazil, and so on and so forth. So there is, of course, a racial variation that you understand from different countries and different, not each segment, but at least in various countries, there's a different range of the penile sizes. So you need to know. We've recently been doing a study on the penile size in JPMC, and it's still not finished, but it's very similar to the results that are shown in the Indian studies. So what's the etiology when we talk about the micropenis? Of course, we have one end, the HPGA axis, the hypothalamic pituitary gonadal axis, and we talk about isolated hypoc, Kalman syndrome, GnRH, DAX1, isolated growth hormone, IGF-1, multiple pituitary like PIT1, PROP1, and HESX1, and then various syndromes, exposure to the medicines, homeobox gene defect. And then on the other hand, we have the gonadal problem like the anorchia, LH receptor defect, टेस्टोस्टेरोन बायोसिंथेटिक इफेक्ट जो हमने शुरू में दिखाए थे आपको 1720 lyase 5 alpha reductase, and then defective action of the testosterone like the partial androgen insensitivity and the complete androgen insensitivity, and the various syndromes like Klinefelter, Downs, Noonan's, Robinow, so on and so forth. This list is not complete, it's not ending. So, of course, there are a number of other syndromes that are associated with it. So now a simple schema, I think this is very useful. Karna kya hai aapko? So whenever you find micropenis, first of all, you look at the karyotype. Again, if it's 46XX, then it's a different scenario. And you talk about the CAH and the other XX disorder. Let's assume it's XY. Again, you look for the DSD and other syndromic, and if you find things that are pertaining to DSD, then you go down that route and look at the various causes of DSD. But if you don't think it's DSD, then and the child is still in the mini pubertal age, then you do the basal and on stimulated FSH, LH, testosterone, and DHT. So that's what you do when you get this mini pubert micropenis thing. So now let's look at that. If all these results are normal, then you can relax and may say this is just an anatomical defect. If you have a low FSH and LH and a testosterone, then we are probably talking about the congenital hypogonadotropic hypogonadism, either alone or with multiple pituitary. If you have a high FSH and LH, but a low testosterone, then we are talking in some form of gonadal dysgenesis, testicular regression, or biosynthetic defect. And if you have a high FSH, high LH, and a high testosterone, then you need to do one more test, which is the ratio of the testosterone and DHT. And if you have a high ratio, then you have a 5 alpha reductase. And if you have a low ratio, then you have an androgen insensitivity. So this is a very nice, simple schema that will take you through the management of what you want to do with the micropenis. And once you find the micropenis, then you need to treat them. You can't leave them like this. The only problem is the availability of these injections, which I'll talk about. So you ideally should be giving them a little short course of testosterone, only 25 milligram every 4 weeks for something like 3 to 4 weeks. And generally it is good enough to make at least 100% increase in the size of the penis from the baseline. And that's considered, of course, a good response. If there's no response and it's still less than 1.9, and that's kind of a treatment failure. You may want to repeat it at some point in time. But one of the problem is in the availability of this 100 milligram dose. Normally you get the 250, but it's very difficult to give us 25 milligram from the 250 preparation. You also use sometimes the local DHT cream. Again, this is not very frequently available, but even if it is available, there's a little bit of discussion as to what dose and how long you should use it. Sometimes people have used it a combination or recombinant FSH, LH. 2-3 studies have been there. They have increased, some of the increase have increased the size of the penis, some have increased the size of the testes. But it's again not a very clearly recommended treatment. And finally, sometimes you can resort to surgical treatment. Goes without saying, which we don't unfortunately have, you need a multidisciplinary team, which all of these conditions are like, all of these categories are self-evident why you need them: pediatricians, surgeon, urologist, psychiatrist, radiologist, geneticist, and an adult endocrinologist, which unfortunately, we've just been talking about that the transition between the pediatric and an adult is a challenge that we need to address. So the microphallus, as I said, is a term slightly loosely used. When you have the micropenis along with hypospadias. What do you do when you have a similar micropenis at during the childhood years? Again, you have the chart as a reference point. But the commonest scenario is what we practically see in children who are obese, and the mothers are coming with a penile size like this, and they are extremely worried about the penile size, and the child is sometimes worried, but the parents are usually very worried because they see other children and all that. But if you try and examine it and just push the fat a little bit, then the scenario completely changes. So most of the time, this is what we call as a buried penis because of the lot of suprapubic fat that is around that area. So what is buried penis? Basically, it's a hidden or a retractile penis, which is behind, partially hidden, partially because of this large amount of fat that is, you can see around here and you can see around here, which pushes the penis inside and then results in what we call as a buried penis. It can be congenital, but it's generally acquired because of the obesity. And it results in lots of problems like the bacterial overgrowth and placental over balanitis, UTIs, and sometimes even erectile dysfunction have been reported later on in life. Generally, you don't need to do surgery. We try and reduce the fat, try to reassure them, tell them to, bring the weight down a little bit, and the penile size will grow when the child goes into the puberty. So that's generally enough, but sometimes if it's a huge problem, then you need to do a little bit of pediatric surgical things, like the adiolysis, the suprapubic fat is removed, you detach the ligament, you do a little bit of skin grafting and something what is called as a tummy tuck, removing that extra fat. Then there's another category which is called the webbed penis, and it's again a congenital condition where there's a web or a fold which obscures the penoscrotal angle, which is in otherwise normal size penile shaft, and that gives you a pseudo appearance of the micropenis. So that's not a true micropenis, but the web actually holds it like this and then doesn't let the penis grow. So it appears like a small penis where it is a normal size penis. And now there's been a recently classification of this condition, which divides it into a simple and a compound webbing. The simple webbing, of course, is limited to the webbing, but the compound webbing is when you have a prepenile scrotum. So the scrotum kind of overlays it like this. So this is a simple webbing, but this is more of a compound webbing when the scrotal skin is also surrounding that. Then there's another condition called the trapped penis. The trapped penis is not congenital, and it's a normal size, again, a normal size penis, but because of the scarring of that area, sometime in overzealous circumcision, the inappropriate circumcision, over exuberant circumcision, or misdiagnosed concealed penis की वजह से उसकी circumcision कर दी है. So the penis goes inside and it is trapped inside. So that is called a trapped penis. Generally, for this condition, you don't need to do anything. You need to apply a little bit of topical betamethasone and do a little frequent manual retraction. And that, in the majority of the situations, resolve the problem. But very rarely a surgical correction is required. So now we come to adolescent, and I'm not going to delve into this area because there's going to be a talk by better speakers than I am on the topic of pubertal delay, and they will deal with hypogonadism, and we will be still talking about micropenis in that area. I just have to remind you that even in the adolescent age group, all boys who are over the 14 should be investigated. We do have some forms of DSD presenting at this age, especially if you get a history of hypospadias repair or an orchidopexy at the earlier age. Beware that they can have a degree of DSD. Or, of course, you need to rule out this overweight boy and the buried penis type of situation. But you have to understand that you do get some partial androgen insensitivity, even testosterone biosynthetic defect, and testicular dysgenesis at the age of puberty. So it's not all very obvious. And I'll leave you after this one last slide, which is just showing you a glimpse of how complex this has now become. And if you look at the genetics of the congenital hypogonadotropic hypogonadism and what we call as a constitutional or a simple delay in growth and puberty, then these are the genes that are involved with the development of the migration from the olfactory placode into the hypothalamus and subsequently into the pituitary of the gonadotropes, their differentiation, their migration, and then further action. So these are the genes that are involved for the CHH or the hypog. The ones in the green are the ones that are involved with both hypog, as well as the constitutional delay. Even the constitutional delay is now being caused by these genes. And then the ones in the yellow are the ones are just involved with the constitutional delay and not with hypog. Sorry, फिर आपका ये आ जाता है Skype वाला. फिर अटक गया. हाँ, okay. So now, in summary, अच्छा ये कहीं कहीं अभी एक टर्मिनोलॉजी इस्तेमाल की गई. I found it a little derogatory, so I have not used it. A small penis has also been described as inconspicuous penis. So anyway, whatever term you want to use, you can use it. But remember that it's probably more common than we appreciate. And it is a cause of very serious concern, both for the parents and for the children. Of course, for the younger one, it's the parents which are mostly concerned. But the young boys, when they're going into the teenage and even before that, even the school ages, sometimes they are teased by their classmates, their siblings, their cousins, whatever. And the parents, of course, have a very serious fear of what is going to happen when they grow up, whether they'll be sexually active, whether they'll have problems in their married life, and so on and so forth. So it's important to differentiate between a true micropenis and just the other types of small penile size that we have mentioned, the webbed one, the buried one, the trapped one, and all those. So that you need to investigate the true micropenis from the others. And as I said, it's, when it's a true micropenis, it needs proper evaluation. But remember that it's very important to counsel the families when you see them. You have to reassure them really well. If you think this is normal, if you think there's nothing wrong with the penile size and it's just like a buried penis and all that, even then you need to allay the anxiety, you need to follow them up, you need to make sure they understand why you're not doing it. मेरे पास आते हैं कई दफा, मतलब most of the time, of course I see them a lot of time, and I tell them practically कि देखें अगर ये problem थोड़ा है भी इसको तो we are not going to do anything right now. They'll be talking about delayed puberty later on. So we don't treat delayed puberty before the age of, when they are supposed to be in the puberty. So we are talking about the other than the micropenis and just like a buried penis and all that. So in order to allay their anxiety, you need to tell them that you're not going to do anything before the age of 13 or maybe 13 and a half, whatever. So might as well wait, cut down the weight and do the other things, and hope that things will get better when they go into the puberty. So thank you very much for your patient listening. Stop it.
Thank you, sir, for such a wonderful presentation. So we will take the question answer at the end of this session. Next, I would like to invite Professor Dr. Khadija Nusrat Humayun, and she's going to talk about precocious puberty in girls.
Assalamu alaikum. Uh, Thank you to the organizing team from PES for first of all, for arranging this nice collaborative series of webinars and now the seminar, and for giving me a chance to speak on this topic. So I've tried to keep it very simple as I can. But if there are any questions, we will have time later on. So I'll be talking specifically about the girls, and my colleague, Dr. Mosana, will talk about the precocious puberty in boys. Things are happening too fast. The child is very young, and understandably, the concern is there. So I have no conflict of interest to declare. Before I start my presentation, let's look at these clinical scenarios. A 5-year-old girl comes to your clinic and mother is concerned there is breast development with or without pubic hair. A 7-year-old girl with just pubic or axillary hair growth. You must have seen all these things coming to you in your clinics many a times. Or an 18-month-old baby with breast development. These are the things that we need to look at and be able to differentiate from one another and decide where is the chance for us or where is the need for us to intervene. So before we go on to the precocious puberty, let's talk a little bit about the normal puberty, the consonants, and then we move on. As Dr. Jamal has already pointed out, there is a mini puberty in the neonatal and infantile period. But once that has happened, everything goes into sleep. And then the reawakening of the hypothalamic pituitary gonadal axis happens around the time of puberty. This is due to the pulsatile secretions of the GnRH, stimulating hormone, gonadotrophin is stimulating or releasing hormone, and after which the puberty starts. And in the girls, the first sign of puberty would be the breast development, which we also called as telarchy. We all know that the HPG axis comprises of hypothalamus, pituitary, and gonad, and anything happening at any of these, from the brain to pituitary to gonad, things can go haywire. So what is the normal timing and sequence of puberty for girls? Unfortunately, Pakistan की population के norms available नहीं हैं. But जो international norms available हैं, उनके हिसाब से, let's look at that. Way back, Dr. Tanner and Whithouse, they worked on these, and I'll give you my references towards the end. So thelarchy, pubarchy, and then comes the growth spurt, and finally the menarche. The menarche is the culmination of puberty. And at times, I think we do face the question of the height growth, the growth spurt in these girls that parents come to us at once the menarche has happened. So we have to understand that this thing has already happened before the menarche. So the ages roughly from the Western population are about 9 to 11 years for their happening. And menarche is 11 to 12 years, but even 10 is taken as normal with the growing, changing scenario of having early puberties. So this graph very conveniently depicts what is happening, and you see what it be. So around the age of 10, when the breast starts, and then comes the height spurt, and the pubic hairs are following through. And then this graph tells us the time lapse to menarche. Once the breast development has happened, how much time does it take for the menarche to occur? So the later the breast development, the later the thelarche, the shorter is the time lapse required for the menarche to happen. What is very important is the harmony or the consonance. And when we के हिसाब से हर चीज ने होना है. And if things are going haywire, like for example, if the thelarche and pubarche has not happened stepwise and the child presents with vaginal bleeding, then you have to think there is something that is going haywire, something is wrong, and we need to look into that. So whenever the normal consonance is missing, do think of some endocrinopathy or something else going on and look into that. Mean age of breast stage 2. Stage 1 in the Tanner means childlike. Stage 2 is when the development starts. And so the mean age, again, with the Marshall Tanner's work that was done back in 1969, is reported to be between 11.15 years with as SD of 1.1. So somewhere 10 से लेके 12 साल के दरमियान, the breast stage 2 used to appear in those girls. And you see the pubic hairs follow suit. And just as a reminder, I've added this Tanner stage diagram. I know you know it all too well. So for the girls, we look at the breast staging, the axillary, and the pubic hair. And Mohsena would be talking about the genital staging of the boys. So puberty happening, the pubarche or adrenarche and the menarche or thelarche is under the influence of two different gland system. Adrenarche is coming again from the hypothalamus onto the pituitary, from where the ACTH comes in, acts on the adrenal glands, stimulates them to release DHEAS, and as a result, the adult body odor, the pubic hair, and the growth spurt that is happening occurs. Whereas the menarche and the thelarche part comes again from the hypothalamus. So you do understand how important the involvement of brain is with GnRH coming and stimulating FSH, LH release from the pituitary, and it acts on the ovaries to cause release of estrogen, as a result of which the breast development and menstruation happens. Now, there are certain factors which have been looked at as to what affects the timing of puberty. And it has been found that it may run in the family, the genetics, that mother ki menarche happened, say, early around 10 and a half. 11, and the girl is likely to follow suit. The race also counts. So it is a known fact that the African Americans and the Hispanics in USA tend to have their menarche, their puberty earlier than the Caucasians in the environment. The low birth weight not only exposes them to this, but also to a lot of other things like the metabolic syndrome, the insulin resistance, and short stature. So low birth weight is also a factor, probably because of that metabolic syndrome and insulin resistance pathway kicking in, which causes them to have early puberty. But not necessarily low birth weight leading to obesity. Any girl with rapid weight gain or obesity is likely to have an early puberty unless the cycle of PCOS sets in secondary to that obesity. It has also been seen that uh, because of the effect of hypothalamus involvement in this cycle, the adopted girls, the exposure to endocrine disruptors, the girls who belong to one race and were taken to another continent and were brought up in different circumstances, they were found to have early puberties. But as I said earlier, we unfortunately have no studies available from our part of the world, especially from Pakistan, to be exactly knowing what are the exact timings of onset of puberty. Now, what is precocious puberty? Having pubertal development at an age which is about 2 to 2 point standard deviation, 2.5 standard deviation earlier than population norm. So do think that like all the things that we talk about, it's a bell curve. And in the bell curve, we have to think the distribution of things would be happening with, and they are called standard deviations. So for anything to be abnormal, like in short stature, we called a child short when he or she is about 2 to 2.5 standard deviation below the mean. Similarly, a precocious puberty is when for that population norm, whatever that is, the puberty is happening about 2 to 2.5 standard deviation earlier. And the girls, as a general rule, we say that if a child presents to you before the age of 8 with breast development, then think precocious puberty and do try and find out what is happening. So before we move on into the intricacies of precocious puberty, why is it happening? What is the cause? How to manage it? There are certain terms that are used, and I think you all should be familiar, like early puberty, which is the normal variant, whereas precocious when it is happening before the age of 8, thelarchy, pubarchy, adrenarchy, what is the difference between the two, then gonadarchy, the central precocious puberty, which is called as the true or GnRH dependent precocious puberty, and then the gonadotrophin independent, or also called as peripheral or the pseudo precocious puberty. And then as usual, जब हमें किसी चीज की कोई वजह नहीं पता होती, तो we call it idiopathic. As Dr. Jamal has pointed out, just like the CDGP, there may be a time coming soon when all these idiopathic precocious puberty girls would have a genetic cause for their early puberties. Now, let's go back to the 3 cases that we talked about. The first one, where it was the 5-year-old girl whose mother noticed that her daughter seems to be developing breast, and she has brought that girl to York clinic for checkup. So अब इसके हवाले से देखते हैं कि बच्ची 5 साल की, it means earlier than 8 years, and probably we have to do something. अब वो something क्या है? What is the differential diagnosis happening in a 4-year-old or a 5-year-old, which you have to think, आपको अपने दिमाग में वो तमाम वजूहात लानी पड़ेंगी कि क्या हो सकता है. And as we looked into the terminologies, it's always very easy to make a planner. चीजों को किसी स्कीमा में फिट करने से चीजों का जवाब मिलना बहुत आसान हो जाता है. तो we have to ask ourselves, can it be true precocious or central puberty, which is going to be gonadotrophin dependent, or is it pseudo, which means that यहाँ मसला नहीं है, problem कहीं और हो रही है, either there is some tumor in the ovary or something else which is causing it. So this is a diagrammatic interpretation of how to differentiate between two. So if you see, in this case, it is the GnRH, FSH, LH, and as a result, in the girls, the ovaries would be affected and the secondary sexual characteristics would. But over here, the GnRH is not activated. And there is something else happening from where the hormones are coming from, and as a result of which the secondary sexual characteristics are developing. So there is a long list of etiologies. As I said, idiopathic, when we don't know the cause, सब कुछ करके देख लिया, पता नहीं है. But central में idiopathic causes are there when there is no underlying pathology, but it is very commonly associated with CNS pathology. We have to remember that girls who have cerebral palsy or girls who have had a major trauma to their head, road traffic accidents, or congenital anomalies of the brain may actually present with precocious puberty to add to the suffering of the parents and management issues. But in addition to these genetic things, any tumor, irradiation exposure, chemotherapy exposure can also lead to precocious puberty. We know that most of the chemotherapy or radiation exposure patients come to us with delayed puberty, but we have to remember that actually this may happen too. And then when we come to the peripheral causes, the one syndrome, McCune-Albright, which causes the functional ovarian cyst, the giveaway, which would be the cafe au lait spots or the bony deformities, fibrous dysplasias of the bones, is amongst the commonest. But in addition, any tumor of adrenal ovarian origin can cause it. Now, these last three need a little bit of discussion. Primary hypothyroidism, why on earth would that cause it? But we all know it's a very common finding because of the structure of TSH, which is very similar to the FSH, and as a result of which it causes the stimulation of the ovaries, and as a result of which this von Wick-Grumberg syndrome. So we also have to remember, Dr. Mosana has actually published a paper on these girls presenting, but we is where the precocious puberty is happening, but the bone age is delayed. A very important thing to remember. क्योंकि hypothyroid है, तो bone age advance नहीं होगी, unlike in other forms of puberty. Similarly, congenital adrenal hyperplasia के अंदर, although puberty हो रही है, but it would be more of virilization. I remember very well in my residency days, this topic used to be a dilemma for me. Isosexual precocious puberty, heterosexual precocious puberty, gonadotrophin dependent, non-gonadotrophic dependent. So with CH, you have to remember that it is actually the heterosexual precocious puberty because the excess amount of androgens are acting to virilize the girl, but ultimately these testosterone or the androgens are getting aromatized in the tissues to produce estrogen, as a result of which we do see precocious puberty. So that is a very important giveaway that sign of virilization would be present. And then exogenous steroids can be the steroid creams, can be in rare cases use of OCPs, in certain circumstances, maybe not in our culture so much, but more in the West, but they tend to also present with precocious puberty. Now, you remember the girl who was an infant, the third case, who presented with breast development. So a case of premature thelarchy starts before 3 years of age, can be unilateral. It does not cause the rapid or advanced bone age. The uterine and ovarian size would remain prepubertal, and it usually represses with time. But if we are seeing this happening after the age of 3 years, there are chances that it may progress to a central precocious puberty. The mechanisms are still unknown, but the postulated theories are increased sensitivity of the breast tissue to whatever little amount of estradiol that is in the body, or there are transient estradiol secretions caused by the ovarian follicular cyst, maybe precursors of the adrenal origin, or the dietary component, contamination of the food, or transient partial activation of the HPG. So what we have to remember here is anything happening before the age of 3 is very likely to regress, but after the age of 3, the chances is that it may move forward. Then the second case, where there was no breast development, but just the growth of pubic hair. So adrenarche is awakening of the adrenal glands, and pubarche is the development of the pubic hair. It happens secondary to the adrenal hormones, and what we need to consider is if it is happening too rapidly, too fast, and too much, and there are signs of, in addition to pubic and axillary hair growth, virilization, hair growth, hirsutism, acne, then you need to consider, can there be an adrenal tumor which is causing this to happen, or is it a case of CH causing all this? Sometimes it is the only sign of, or an early sign of the girl having the chances of developing metabolic syndrome and PCOS. Now, after leaving that girl with the breast growth and mother concerning around 5 years of age, we went to the other two cases where there was just thelarchy and pubarchy. Coming back to the girl who was 5-year-old and had breast development, we looked into the differentials. And now, what is the information in history that you want to make a diagnosis? जाहिर है अम्मा ने तो हमें सिर्फ यही बताया है कि breast growth हो रही है. What else do you want to know? These are the things that we need to know. Puberty कैसे हुई, किस चीज से बात शुरू हुई, onset कैसे हुआ, आपने कब नोट किया, कितनी तेजी से progress हो रही है, is there any other clinical signs is there height acceleration? साथ में headaches, visual changes, कोई seizures की history, कोई past history of head trauma, previous CNS disease, radiation, all that is important. And then we also have to think about the pseudo precautious and ask about abdominal pain. Has there been bleeding from vagina or any signs of virilization? So a detailed history would help us in, shortlisting from our long list of differential diagnosis. Past history, family history, and medication history is also important. We earlier talked about the genetics or the family history playing a role. So that is very important. Is there a history of early puberty, history of infertility or CH? Parents की height क्या है, उनकी puberty कब हुई थी, or फिर as we talked earlier, the medication. If we take a detailed history, things get, shortlisted, and it's very easy to make a plan for what else to do. Examination, जब आपने history ले ली, तो then you have to think, what is it that I want to? आपने उस 25 की लिस्ट में से जब हिस्ट्री आपने ले ली, तो मोस्ट लाइकली 15 टॉपिक आउट हो गए. अब बाकी जो 10 कंडीशंस हैं उनको आपने मजीद नैरो डाउन करना है. एन एग्जामिनेशन वुड हेल्प यू गाइड व्हाट लैब्स टू ऑर्डर, व्हाट path to take. So look at the height for age. We have already asked, has there been a rapid height growth? Lekin is वक्त is she one of the tallest in the class? अपनी age के हिसाब से उसकी height कहाँ है? Is there, in addition to the breast enlargement, is it really the glandular enlargement? We hope that it's just the fat lipomastia which is causing it, but we need to palpate and find out if we feel the glandular tissue. Is it tender? Is there any discharge? And then the neurological examination, because the hypothalamus is the culprit in most of the cases. So we need to do that, examine abdomen for any masses. And of course, any girl after 10 deserves to get a Tanner staging, whatever she's coming to you for, because that's how we get to know what development is happening. And then it's always good to do a genital examination looking for the clitoris. ये भी हो गया. अब अगला काम है कि माँ को हमने बताना है कि हो क्या रहा है, क्यों हो रहा है. So that is where your investigations are going to come. But remember, if you have done a very good history and physical examination, these labs are not going to be haywire right and left. We can very easily decide हमें करना क्या है. So जो basic चंद labs हैं, उनमें gonadotropins, LH-FSH level, estradiol level. Although lab parameters for estradiol assays are not very good, but at least we have to do to find out if it is above the basal level. We know very well that TSH can be a culprit, so we need to include that in the initial, and bone age. That comes to help. Bone age advanced hai, so there is estrogen somewhere coming from any source, and we need to find out. So these are the basics. And remember, the cutoff for LH, anything 0.3 or more suggests that puberty is happening and the child is pubertal. Further hormonal evaluation में GnRH stem test है. Unfortunately, GnRH is not available anywhere in Pakistan. There are studies and guidelines available which have utilized the GnRH analog stimulation test, but the evidence from pediatrics is not very massive. So we tend not to use it, although when you are stuck, that may be the only way you can do. And you see what is happening is in the case of true precocious puberty, the level of your FSH, LH is going up, whereas in the case of pseudo precocious puberty, it remains static. रेडियोलॉजिकल evaluation में हमने bone age की तो बात की, लेकिन अगर if we are thinking in terms of pseudo precocious puberty or non-GnRH dependent puberty, then pelvic ultrasound or an abdominal ultrasound to look at the uterus, the ovaries, and maybe the adrenals is helpful. Skeletal survey, if we are thinking about McCune-Albright, if we are thinking of any of the congenital syndromes in which the CNS is affected, and later on, once we know that it's probably a central cause, then CT, but preferably an MRI, is to be done specifically in girls who are having precocious pubertal signs less than 6 years, or in case where there are neurological findings. So once we have diagnosed, how to treat, and the treatment would totally depend upon the exact etiology. Of course, in the case of McCune-Albright syndrome, anti-estrogens and aromatase inhibitors are to be used. You cannot use the GnRH analogs there. But in the case of central precocious puberty, GnRH analogs are the mainstay. If it is an ovarian cyst, if it is an adrenal tumor, if it is a CH case, then you treat accordingly. But for central precocious puberty, GnR, especially the idiopathic varieties, you use GnRH analogs. Now, when to use it and what would they offer? There are if the girl is 7 or less, the height preservation is achieved. If we give it to the younger the girl, the better the outcomes as far as the height is concerned. But we also have to remember that height is not always the case. Sometimes it is the peer pressure, how the girl psychologically is capable of handling, or sometimes the child is developmentally delayed, has neuromuscular deformities where the GnRH analogs are used and have been helpful. While using them, the parents usually ask us, what are the side effects? That they can, just like any other, can cause an allergic reaction, can cause nausea, vomiting, but it has been well studied that in the long run, they do not have any effect on the fertility or in the uh, recurrence of puberty once they are stopped. We also have to remember that the first time that we use it, there are chances of some bleeding, pervaginal bleeding happening because of the estrogen withdrawal, but then they tend to control it. I've not gone into the dosing details because I thought that would be probably not the domain of this talk. And with that, I finish. Thank you very much.
Thank you, Dr. Khadija, for such a simple but practical approach. Next, I would like to invite Professor Dr. Mohsina, and she is going to talk about precocious puberty in boys.
Assalamu alaikum, everyone. Um, Thank you so much, Dr. Khatija and Dr. Jamal, मेरी जिंदगी थोड़ी सी आसान करने के लिए. Nice to see everyone here in the morning, and especially after gynae, I think endocrinology is also dominated by females. सब मैं और सर यही बात कर रहे थे कि तमाम माशाल्लाह खवातीन ही हैं और कुछ ही like men हैं, but definitely actually the females are more prone to endocrine issues. Their all life is hormonal. उससे इबारत है हमारी जिंदगी तो up down. So I think it's for all of us, it's very close to the endocrine thing is very close to especially the female population. Maybe I'm a little biased, but this is what it is. So I'm going to talk about precocious puberty in boys. तो जो चीजें जो आपने पहले देख ली हैं उसको जरा हम जल्दी गुजारेंगे एंड देन वी विल गो टू द एंड कि हमारे पास क्या इश्यूज हैं और लेट मी टेल यू कि ज्यादा कॉमन ये फीमेल्स में है तो इसलिए बॉयज में आपको कम मिलता है एंड ये दिस इज माय मदर इंस्टीट्यूट एंड प्यूबर्टी की डेफिनेशन और उस पर ये हमारा ऑब्जेक्टिव है जो हाउ लिटिल बिट अबाउट प्यूबर्टी एंड प्रिकॉशियस प्यूबर्टी क्या क्यों एटियोलॉजी क्या है इवेल्युएशन के लिए क्या करना है ऑफ कोर्स द ट्रीटमेंट डोमेन इज लिटिल बिट मोर एंडोक्राइन a sort of a very speciality, but we will discuss in the end a few clinical cases also and some key messages. इस पे बात होगी. It's a wonderful period in which an individual acquired the capacity to reproduce. This is the basic issue कि हमारी जो human beings की जो reproduction की capacity है basically वो achieve करना होता है but it is combined with several other things. इसमें growth भी होती है, इसमें आपका hypothalamic pituitary axis भी mature होता है and there are so many things goes by side but the eventual thing is development of the genital organs and reproduction की capability आपकी produce होती है. It's a physiological phase and 2 years से 5 years तक अमूमन ये duration रहता है. अगर इससे लंबा चला जाए या इससे कम हो तो then it is a separate entity. उसको हम arrested puberty भी कभी कभी कहते हैं. But usually 2 years मतलब 10 years से अगर start होता है तो 5 years तक complete होता है. It's a wonderful period. बहुत सारे emotions, बहुत सारी चीज़ों से बच्चे गुजरते हैं. Of course, mini puberty पे बात होगी. It's basically the hypothalamic pituitary gonadal axis की maturation है. Mini puberty कुछ कहते हैं 6 months and some people say it lasts till 2 years, but majority agrees that it lasts for 6 months of age. It's again after the birth there is resurgence of gonadal FSH and LH, which leads to hypothalamic hormone, which leads to mini puberty. Then the HPG axis अभी सबने बात की कि मैं इसी स्लाइड पर डायरेक्टली आ जाती हूँ कि 3 दफा आपका HPG axis लाइफ में एक्टिवेट होता है. Once in the intrauterine life, then at the mini puberty soon after birth, maybe 6 months and sometimes 8 months. तो आपको इन्वेस्टिगेशन कराने में इसको जहन में रखना है. Then it becomes dormant and then at the time of puberty ये दोबारा से एक्टिवेट होता है for the growth, for the reproductive organs. इस पे आगे बात करने से पहले देयर आर लॉट्स ऑफ बहुत ज्यादा इस पीछे 5 years में जेनेटिक्स पे काम हुआ है एंड देयर आर लॉट्स ऑफ जीन्स हैज बीन डिस्कवर्ड एंड इट हैज बीन सीन दैट every cell is affected by different genes. MKRN3 जीन है, KIS1R जीन है, किस जीन है जो कि एक प्रोटीन बनाता है, किस पेप्टिन. दिस जीन इज सेड टू बी समझिए एक ब्रेकर है इन द इंडस्ट्री ऑफ बायोलॉजिकल रिप्रोडक्टिव मेडिसिन, द KIS1 gene and the production of the kispeptin. This is the basic molecular protein which activates pituitary hormones or the gonadotrophs so that the the puberty starts by the candy neurons and the other neurons. The discovery of kispeptin genes and kispeptin protein is a milestone. It's the increased secretion of kispeptin which actually activates the hypothalamus and the pituitary neurons so that the puberty starts. It's a strange name, but it is actually discovered in the Pennsylvania and so it is given the name of Hershey Kiss chocolate. तो इसका जीन का नाम ही उन्होंने kispeptin जीन रख दिया है. Its signaling is very important in GnRH secretion and LH secretion and is the basic now considered as the catalyst for puberty. This is the famous hypothalamic pituitary gonadal axis. So there are different factors and different chemicals which affects the production of GnRH hormone from the hypothalamus, which acts on the pituitary. FSH LH hota hai produce. LH then of course acts on the Leydig cell and the production of the testosterone is there. सो जैसे डॉक्टर खतीजा ने बात कर ली कि बेसिकली जैसे मेल्स में फीमेल्स में भी दो चीजें होती हैं, एक एडेनार्की एंड एक गोनेडार्की. तो एडेनार्की इज बेसिकली द मैच्योरेशन ऑफ द एड्रिनल कॉर्टेक्स. इट इज नॉट दैट मच डिपेंडेंट अपॉन द एचपीजी एक्सिस, ये खुद से भी एज के साथ साथ हो जाता है. एंड एड्रिनल एंड्रोजेंस तो फेमस तीन हैं, डी हाइड्रो एपीएंड्रोस्टेरोन, डी हाइपर एपीएंड्रोस्टेरोन सल्फेट, एंड्रोस्टेनिडायोन. ये तीन बेसिकली एडेनार्की की वजह से प्रोड्यूस होते हैं. और गोनेडार्की जो है इस बेसिकली अगेन दिस इज वेरी इंपॉर्टेंट दैट इसके लिए आपका एचपीजी गोनेडल एक्सिस नॉर्मल होना चाहिए. एंड इट्स ऑफ कोर्स प्रोडक्शन of gonadotrophin hormones on and then estrogen and testosterone से related होता है the gonadarchy stage. So the first sign of puberty in the females breast development पे बात हुई, लेकिन males में जो first sign है that is testicular enlargement. Even before the onset of the development of the pubic hair, it's basically the testicular enlargement which is the first sign of puberty in a male. So why the testicular, कुछ important बातें हैं, थोड़ी सी busy slide है, but testicular size the first sign, and basically testis enlarges because of the development of the seminiferous tubules. So LH stimulates the synthesis of testosterone by Leydig cells and FSH stimulates the production of sperms. So testicular size increases throughout the puberty from 4 ml to 25 ml. ये जाता है तकरीबन stage 4 तक. Then boys typically experience their first ejaculation approximately after the 1 year when the testes become the, but usually it occurs about 13 to 14 years की age पे होता है. But the sperm production starts after the 1 year of the after the first ejaculation. Usually is before that the fertility is not there, but after that fertility usually occurs in the males also. Then there is a very famous pubarchy, is actually the growth of the pubic hair is first at the spinal base and then covers throughout the genitalia. Initially they are thin, later on it becomes darker and curlier. And after that, after 2 years, facial growth and axillary or chest pe growth hoti hai. So pubarchy is also very important in the male's pubertal development. Then penile size is also very important. It really starts occurring after the testicular enlargement, and the penis grows. So if the penis is enlarging before the testicular enlargement, so it can be something abnormal. So this is also very important to know that the penile size grows after the testicular enlargement in the normal male. Of course, it's the development of glans penis and corpus cavernosum also enlarges. अगेन ये वही स्लाइड है जो डॉक्टर खतीजा ने बात की कि पहले आपका टेस्टिकुलर वॉल्यूम कितनी एज लगती है, 11 इयर्स से ऑनवर्ड आपका टेस्टिकुलर वॉल्यूम बढ़ता है, देन प्यूबिक हेयर आते हैं, देन साइड बाय साइड कंप्लीशन हो जाती है, तकरीबन 16 इयर्स तक एडल्ट वॉल्यूम अचीव हो जाता है, और 14 to 15 इयर्स पर आपके स्पर्मेटोजेनेसिस स्टार्ट हो जाती है, एंड द स्पर्म्स the male can be fertile after that. this इसके साथ साथ आपका ग्रोथ स्पर्ट भी हो रहा होता है, तो ये दोनों हैंड इन हैंड चल रहे होते हैं. ये द फेमस प्राडर ऑक्यूडोमीटर है, आप सब इससे वाकिफ हो गए. विदाउट दिस यू कैन नॉट डू द स्पेशली पीडियाट्रिक एंडोक्राइनोलॉजी ओपीडी. इसके साथ आप कंपेयर करेंगे, हाथ से या अंदाजे से कुछ नहीं होगा. यू हैव टू कंपेयर द साइज ऑफ द टेस्टिस विद द प्रेडर ऑक्यूडोमीटर पे डिफरेंट साइजेस होते हैं. सो यू कैन सी कि कहाँ से स्टार्ट हुआ है. 4 ml से. 4 ml इज अर्ली, यानी 4 ml से प्यूबर्टी स्टार्ट है. 4 ml से कम है और 4 ml के इक्वल है तो प्यूबर्टी में आ जाएगा, एंड देन इट गोज टू द 25 ml का टेस्टिकुलर वॉल्यूम होता है, और साथ साथ आपकी और भी ग्रोथ हो रही होती है. pubic hair penile enlargement is going on. This is the famous Tanner scoring chart. Everyone should have it in a busy clinic. I know it's not easy, but ideally you should examine each and everything and see the testicular size also. ये डॉक्टर खतीजा ने भी ये दिखाई थी, तो मैंने इसलिए इसको शामिल किया कि ये गोनेड्स कैसे मैच्योर होते हैं और ग्रोथ ऑफ द बॉय उसी के साथ साथ हो रही होती है. So precocious puberty क्या है? Is defined as presence of any single sign. एक भी single sign होगा, या testicular enlargement होगी, या penile enlargement होगी, या puberty शुरू हो जाएगी, then it is said to be early puberty, and it is different age, different population में different reported है. So below the mean age of the puberty of that population is will be called as precocious puberty. डॉक्टर खतीजा ने बात की थी 9 years बॉयज में है और 8 years गर्ल्स में है, तो ये आपको याद रखना है. दिस इज वेरी इंपॉर्टेंट. एनी सिंगल साइन, एक सिंगल साइन भी होगा तो आपका वो प्रिकॉशंस में चला जाएगा. बहुत सारे फैक्टर्स हैं, आजकल बहुत बात हो रही है, फेमिलियल है, एनवायरमेंटल है, एथनिसिटी है, क्रॉनिक डिजीज है. एनवायरमेंटल फैक्टर्स जो ईडीसी, ये जो एंडोक्राइन डिस्टरप्टर्स पे भी बहुत बात हो रही है, और इसका फीमेल्स में ज़्यादा कहा जाता है कि फाइटोएस्ट्रोजेंस का ज़्यादा रोल है, एंड probably the girls are going into the early puberty because of the endocrine disruptors. Epidemiology again आसान नहीं है. The prevalence and incidence vary among the different population, क्योंकि different population का अपना एक ethnicity है, but overall there is strong female preponderance है. 23:1 का ratio almost, यानी girls में ये इतना common है कि इस almost 100% जो girls हमारे पास ज़्यादातर आ रही होती हैं early precocious puberty के साथ, majority of them are girls. So types क्या है? Gonadotrophin dependent होगी, gonadotrophin अगर आती है ज्यादातर, ओवरऑल प्रिकॉशंस पुबर्टी 80% सेंट्रल होती है. gonadotrophin इंडिपेंडेंट या पेरिफेरल कोई कॉज है तो उसको वो हम पेरिफेरल में डालते हैं, वो रिलेटिवली लेयर है. और कॉम्बिनेशन ऑफ बोथ, जैसे डॉक्टर खतीजा ने बताया कि सीएच में बाज़-औक़ात दोनों चीजें, पहले आप एड्रिनल से शुरू होते हैं, इवेंचुअली यू लैंड अप इनटू द सेंट्रल प्यूबर्टी, लेकिन इनको मैं डिटेल में डिस्कस नहीं करूंगी. लास्टली दो चीजों पे बात करना बहुत इंपॉर्टेंट है, दैट इज प्रीमेच्योर एडेनार्की. आई वाज डिस्कसिंग विद सर कि हमारे पास पेशेंट्स लाइक समटाइम्स दे कंप्लेन is so strange to mothers आती हैं या parents आते हैं that the child has a very bad body odor, and it starts very early, 6 years 5 years पे bad body odor शुरू हो जाता है, like, and you can't do much, and the tests are normal, the bone age is normal, and the other adenogens are slightly high, but you can't do much. तो ये एक बहुत important group है जो कि round about 6 to 8 years पे usually आपके पास बच्चे आ रहे होते हैं, and the body odor starts usually from 6 to 8 years. The eventual results of this adenarchy, यानी कि आपका adrenal axis activate जो होता है वो pubarchy में ही जाता है, यानी कि pubic hair और दूसरी growth जो body पर हो रही है. But this is also very important कि early premature adenarchy is a normal phenomena which occurs quite commonly. इसमें bone age advance नहीं मिलेगी और आगे की चीजें advance नहीं मिलेगी. And very important and very frequently seen in our clinics is the gynecomastia. Puberty associated gynecomastia is also quite common in boys, and it's the appearance of a large breast during puberty. Gynecomastia is a benign condition characterized by proliferation of glandular elements, which results in enlargement of sometimes one and sometimes both the breasts. Is a short-lived imbalance between estrogen and testosterone. Majority जो है usually resolve हो जाता है 18 years, लेकिन it do causes a lots of issues. Psychosocial issues हो जाते हैं, बच्चे स्कूल नहीं जा रहे होते हैं, and there are so many issues, and sometimes you have to give some medication after an investigation, and sometimes you have to go for surgery if it is not resolving. But majority of the cases में it resolves on its own. आप टाइट क्लोथिंग एडवाइस कर देते हो और टेस्ट बेसिक्स करा लेते हैं, एंड देन इट रियली रिजॉल्व्स. सो you should be aware of this also. Now coming to the central precautions puberty, जैसे डॉक्टर खदीजा ने बताया, मेल्स में भी इडियोपैथिक से ज्यादा जो पहले दो पर बात हो रही है, इन अडॉप्शन पे बहुत बात की हुई है. जो इनका लिटरेचर कहता है कि जो अडॉप्टेड बच्चे हैं उनमें प्रिकॉशंस पुबर्टी somehow or the other because of the psychological factors is very common. Then in majority in the boys, the central cause is pathological. You have to see the CNS causes. फिर जेनेटिक कॉजेज है, मैं इसकी डिटेल में नहीं जाऊंगी. बहुत सारी जीन्स हैं, किस पेप्टिन जीन है, मैकोरिन MKRN3 जीन है जो कि सेंट्रल प्रिकॉशंस पुबर्टी का, स्पेशली इस ग्रुप को इडियोपैथिक या जेनेटिक ग्रुप में डाल दिया गया है. इसके अलावा देयर इज अ सेपरेट ग्रुप देन जेनेटिक ग्रुप इज द सिंड्रोमिक फॉर्म ऑफ विच इज एसोसिएटेड विद सेंट्रल प्रिकॉशंस पुबर्टी, जिसमें बहुत सारे रेयर सिंड्रोम है, पेलिस्टर हॉल है, न्यूरोफाइब्रोमाटोसिस है, TS है, वो सब इसमें आते हैं, जिसमें अदर सिंड्रोमिक फॉर्म्स ऑफ प्रिकॉशंस पुबर्टी इंक्लूडेड है. इसके बाद आपकी पेरिफेरल प्रिकॉशंस पुबर्टी जो कि बॉयज में एज कंपेयर टू गर्ल्स इज मोर कॉमन. बेसिकली दो इसके ओरिजिन है, या तो एड्रिनल से ओरिजिनेट हो रही होती है इधर, और या टेस्टिकुलर कॉज होती है. एड्रिनल में द मोस्ट इंपॉर्टेंट इज CH. एग्जामिनेशन पे एक फाइंडिंग होती है जो मैं आपको आगे बताऊंगी. देन यू कैन डिफरेंशिएट इवन ऑन एग्जामिनेशन दैट दिस कैन बी CAH और दिस कैन बी अ टेस्टिकुलर कॉज और सेंट्रल सॉरी CAH और पेरिफेरल प्रिकॉशंस प्यूबर्टी और सेंट्रल कॉज. टेस्टिकुलर में आपके एक्सोजिनस हैं. I have read a case के father was using the testicular cream for the testosterone cream for the muscle growth, and the boy developed the signs of precocious puberty. So you have to be very careful कि अगर आप किसी को prescribe कर रहे हैं, especially adult endocrinologists are sitting. So boy used to go, the child was used to go in the lap of the father, and he also developed the sign of precocious puberty. It was really a astonishing case. And the endogenous production, your testicular tumors हैं या testicular कोई भी pathology है, testotoxicosis है, and then they cause it. This is again समरी में मैं आपको बता दूंगी कि etiology की बहुत मुझे अच्छी लगी थी, so I included it. Gonadotrophin independent है, endogenous में दो sources हैं आपके, testicular और adrenal. Adrenal में आपका 21 hydroxylase is famous to cause precocious puberty, or 11 beta hydroxylase. These two are very common. And then don't forget adrenal tumors, so you have to go for ultrasound. Autonomous testicular tumors हो सकते हैं, and then in males also mecunal bright testotoxicosis and HCG producing tumors is a separate group. In central, mostly it is the brain tumors or CNS pathologies. Approach में don't forget your basic history and clinical examination. इस पे बहुत कुछ clear हो जाता है और उसके लिहाज से आप tailored investigations कर सकते हैं. And then of course the boys can present with any of these signs. किसी भी age पर वो किसी भी sign के साथ, for example, a 5-year-old child presenting with acne can be abnormal. So किसी भी presentation के साथ बच्चा किसी भी stage पर आ सकता है before the age of 9 years. All of them should be considered as early puberty. Even the adult body odor before age of 9 or 5 is sometimes abnormal. History में आपको external source की बात करनी है, detail history लेनी है. डॉक्टर खतीजा ने बहुत इस पे अच्छे से बात कर ली है. न्यूरोलॉजिकल एग्जामिनेशन इज एक्सट्रीमली इंपॉर्टेंट. फंडोस्कोपी करनी है, पेप्लेटीमा देखना है, and other signs देखने हैं. Then on physical examination, don't forget to see the cafeole. हम लोग जब आते हैं patients precocious puberty के साथ, we have to see cafeole. Cafeole से आपका mecunal bright neurofibromatosis exclude हो जाता है. So sometimes these little findings can help you a lot in your diagnosis. And examination is very important. Height or weight ज़्यादा होगा. Then comes the examination of the Tanner scoring. टेस्टिकुलर, ये कन्वेंशनल टीचिंग है कि अगर टेस्टिकुलर वॉल्यूम इक्वल टू और मोर देन 4 ml है, 4 ml से ज्यादा है, तो it is 90% it is central precocious puberty. And if it is less than 4 ml, then this is a peripheral precocious puberty. यानी अगर testicular volume normal है, बच्चे के अंदर और precocious puberty के signs हैं, then it is mostly peripheral precocious puberty. But if the testicular volume is more than 4 ml, 5 ml or 6 ml, and the other signs are not there, testicular volumes are there, so this is more likely 18% it is central cause of precocious puberty. Hormonal S से आपने कराना है, अभी lately जो add हुआ है वो किस peptin level है, मगर ये fertility और उसमें ज़्यादा important है. Initial first line FSH LH है, डॉक्टर खतीजा ने बात की है. टेस्टोस्टेरोन, dihydroepiandrosterone sulfate और 17 OHP levels आपको कराने हैं. This is going to differentiate DHEA, and DHEA sulfate is going to differentiate that this is androgenic and from androgenic surge from adrenals or from this is the other than androgenic surge. Thyroid function extremely important. हमारे पास बहुत बच्चियां आती हैं. Again, the gynecologists are here. Sometimes even the ovaries are removed. Single ovary is removed, that this is polycystic, we have to remove it, and the thyroid function is not done. So you have to do thyroid functions in any case of ovarian cyst. This is my message, and we have seen 2 or 3 cases whose ovaries, the children's ovaries, one-sided ovary has been removed because of the cyst in it, and later on it turned out to be Van Wyck-Grumbach or hypothyroidism. Bone age is also an initial screening. It is always advanced. Baseline pubertal level पे बात हो गई है. Again, boys में भी less than 0.3 is suggestive of, more than 0.3 is suggestive of central precocious puberty. Usually हम कहते हैं 1 और 1 से ज़्यादा है तो it is central. FSH की limited utility है, high level of testosterone मिलेंगे, but mostly GnRH stimulation is the गोल्ड स्टैंडर्ड ह्यूमन कोरियोनिक गोनाडोट्रॉफी डिफिकल्ट केसेस में आपका जीएनआरएच स्टिमुलेशन बनता है मगर मेजॉरिटी ऑफ द केसेस यू कैन डिसाइड दिस इज सेंट्रल और पेरिफेरल इन इन्वेस्टिगेशन अदर देन जीएनआरएच स्टिमुलेशन जीएनआरएच स्टिमुलेशन हमारे पास है भी नहीं इसकी इंटरप्रिटेशन में भी बहुत से इश्यूज हैं बहुत सी गाइडलाइंस है दिस इज बेसिक जिस तरह से किया जाता है एक कट ऑफ मोर देन 5 at 3 hours post administration is a diagnostic of central precocious puberty ये एक बहुत ही मुझे पसंद है लाइक सेंट्रल में होगा तो आपका आई एम सॉरी सेंट्रल में होगा तो आपका एलएच ज्यादा होगा आई डोंट नो व्हाई आई होप यू आर गेटिंग इट और एफएसएच नॉर्मल होगा और इसी तरह पेरिफेरल में आपका एलएच बहुत कम होगा और एफएसएच भी कम होगा examination bone age is extremely important bone age is more than the height age and even more than the chronological age यानी bone age इन दोनों से advance होगी height की एज के हिसाब से भी एडवांस होगी और chronological एज से भी एडवांस होगी तो दिस विल बी हाईली सजेस्टिव ये प्रिकॉशन होगा except one condition in which the bone age is delayed that is hypothyroidism hypothyroidism will give signs of early precocious puberty in males also but the bone age will be delayed तो ये दोनों में ज्यादातर है but it is more commonly seen in the girls इसके बाद हमारी अल्ट्रासाउंड है आपको एड्रीनल ट्यूमर देखना है सीटी एमआरआई ऑफ कोर्स सीटी एड्रीनल इज डायग्नोस्टिक फॉर एनी मैस इन स्पेशली इन द यंग चिल्ड्रन एमआरआई हम करवाते हैं एंड फाइनली अगर नहीं कॉज मिल रही या कोई रेयर कंडीशन आपको लग रही है तो यू हैव टू गो फॉर जेनेटिक टेस्टिंग दिस इज अ बिजी स्लाइड बट वेरी यूजफुल मैं इस सेंटर पे फोकस करना चाहूंगी कि आपने बोन एज करा ली आपको एक्सेलरेटेड बोन एज मिल रही है तो आपने फिर हार्मोन्स बेसिक मेजरमेंट कर लेनी है टेस्टोस्टेरोन ईस्ट्रोजन और एलएच अगर प्यूबर्टल आ गया तो वहीं डिसाइड हो जाएगा कि दिस इज सेंट्रल एंड यू हैव टू गो फॉर MRI brain for any space occupying lesion hypothalamic hematomas in children अगर आपका प्यूबर्टल प्री प्यूबर्टल LHI यानी कि लेवल कम है लेस देन 1 है या लेस देन इवन 0.3 है और अनडिटेक्टेबल थायराइड टेस्टोस्टेरोन और ईस्ट्रोजन है तो तब आपको जीएनआरएच स्टिमुलेशन करवाने की जरूरत है रिमेंबर कि ये होना चाहिए testicular volume more than 4 ml at the age less than 9 so you have to go for in this condition in which there is a prepubertal LH level there is undetectable testosterone or estrogen then you have to go for GnRH stimulation test अगर stimulated more than 5 आ गया less than 5 आ गया है on basal less than 3 है so you have to close you have to give them on close follow up but if it is more than 5 or and the pubertal testosterone is there then this is maybe a peripheral precocious puberty now issues kya hai treatment karna kyun zaruri hai like why you have to treat it of course there is a shorter adult height there are metabolic risks जैसे डॉक्टर खतीजा ने बात की एक्नी हो जाती है बहुत अर्ली एज में इंसुलिन रेजिस्टेंस हो जाती है प्री डायबिटिक हो जाते हैं देयर इज अ चांस ऑफ टेस्टिकुलर कैंसर बिकॉज प्रोलॉन्ग अनट्रीटेड CAH or similar conditions can cause testicular cancer later on या कोई testicular cancer आपसे HCG secreting tumor आपसे ignore कर सकते हैं साइकोलॉजिकल एंड बिहेवियरल इश्यूज आर लॉट मदर्स को बहुत इश्यू होते हैं कि इतना छोटा बच्चा है हम इसको कैसे प्रोटेक्ट करें स्पेशली समटाइम्स अ मदर जो यंग बच्चियां हैं उनकी मदर्स दे आर क्राइंग हम इसको कैसे संभालें बिकॉज ऑफ द ओल्डर अपीयरेंस उनको आपस में पीयर्स में बहुत मसले हो जाते हैं एंड ऑफ कोर्स देयर इज इंक्रीज रिस्क ऑफ सेक्सुअल अब्यूज स्पेशली इन गर्ल्स एंड ऑफ कोर्स सब्सटेंस अब्यूज बिकॉज ऑफ द बिहेवियरल इश्यूज इन बॉयज सो पेरेंट्स बहुत कंसर्न्ड होते हैं कि हाइट कितनी रहेगी बाद में क्या होगा प्यूबर्टल प्रोग्रेशन कैसी होगी और कॉज क्या है ट्रीटमेंट आपको प्राइमरी कॉज को रिमूवल ऑफ द आपकी जो बेसिक रूल्स हैं कि ट्यूमर को रिमूव करें अरेस्ट द साइंस ऑफ प्यूबर्टल प्रोग्रेशन होनी चाहिए एंड फर्टिलिटी शुड बी नॉर्मल आफ्टर द ट्रीटमेंट दिस इज अ वेरी the child will have normal puberty after the stopping of the treatment so but the GnRH analogs are the mainstay of treatment it acts by binding to the receptors in the anterior pituitary and desensitize कर देता है तो इस तरह से आप बेसिकली सेंट्रल और रेडियोपैथिक प्रिकॉशंस प्यूबर्टी को ट्रीट करते हैं सो बहुत सी एडवांसमेंट हुई है बट द बेसिक स्टे ऑफ ट्रीटमेंट जो GnRH एनालॉग्स ही रहे हैं बोन एज एडवांसमेंट देयर इज अ रिमार्केबल रिस्पांस द बोन एज एडवांसमेंट रिग्रेसेस द बायोकेमिकल मार्कर्स आल्सो shows improvement. तो ये बहुत सारी FDA ने अप्रूव कर दी हैं जिसमें आपकी from 3 monthly 6 monthly to 3 monthly to 3 monthly भी काफी सारे हैं. हिस्टोलिन इम्प्लांट भी आ गया जो कि ईयरली है, बट अनफॉर्चुनेटली पाकिस्तान में सिर्फ और सिर्फ 3.75 वाला मंथली एनालॉग इस वक्त मिल रहा है. 3 monthly is still not available and we are using leuprolide acetate in our kids जो कि अर्ली प्रेजेंटेशन के साथ आते हैं. It's very safe with no significant side effects. Sometimes there is local skin reaction and things like that, and with बहुत excellent response आता है. बाद में stop करने के within a year, the patient usually achieves the normal pubertal cycle, puberty after 1 year. Menarche हो जाती है बच्चियों में और males में दोबारा से sign symptoms आना शुरू हो जाते हैं. What about the treatment of peripheral precocious puberty? Again, I have told you the adrenal cause के लिए आपने CH का treatment करना है, hydro और fluoro देनी है, और well controlled CH really behaves normally. और आपने जो दूसरी causes हैं, testotoxicosis हैं, उनके लिए हमारे पास ये receptor antagonist aromatase inhibitors available हैं, which this is also again showing that peripheral के लिए आपने हाइड्रोकोर्टिसोन और फ्लोरिनेफ इस्तेमाल करने हैं for CT for CH and third generation aromatase inhibitor. और GnRH is the mainstay in central and of course the implant भी अब आ गया है. So prognosis is good if you start the treatment early. HPG axis returns normal after the cessation of therapy and normal progression of puberty हो जाते हैं. And the prognosis of peripheral depends upon the cause. कुछ क्लिनिकल सिनेरियोज है मैं जल्दी से डिस्कस कर लूंगी. आई नो वी आर गेटिंग लेट फॉर द टी, बट दिस इज वन ऑफ द वेरी फर्स्ट केस विच वी रिसीव्ड एट NICH. बच्चा आया था हमारे पास एट द एज ऑफ 5 years with the signs of precocious puberty like change of voice, टेनर स्कोरिंग में पिबार्की थी, गोनाड्स इसके स्टेज 4 पे थे, टेस्टिकुलर वॉल्यूम 12 ml और 15 ml का था, एंड पिनाइल लेंथ वाज आल्सो 10 centimeters. So this was the child. We suspected कि testicular volume ज़्यादा है, तो that could be the central cause. And eventually इसका GnRH भी हुआ था because initially at that time इतना easily MRI होता भी नहीं था. But when we did the CT and MRI, it showed subarachnoid cyst that was compressing the pituitary and causing the early puberty or precaution. The child is very well till now, mashallah, and he comes in OPD also. Now, this is another child. He was almost 1 year old. He presented with his laughing. You know what kind of seizures it is? These are the gelastic seizures, excessive laughing. And he had all the signs of precocious puberty. I'm sorry. तो ये क्या हो सकता है? What is this? So this turned out to be hypothalamic hematoma. Again, hypothalamic hematoma को आप कोई treat नहीं करते, ना उसकी कोई surgery होती है. You have to give GnRH analog, and it has got an excellent response. खुद ही like with the age it itself regresses. ये क्या है? Multiple cafe olive. तो central precocious puberty थी, testicular volume 7 ml का था, तो mostly it was, इसमें peripheral भी हो सकती है, central भी हो सकती है. And इसका हमने genetics भी कराया था, तो parents were very कि हमें diagnosis चाहिए. NF1 autosomal dominant था with optic glioma, especially जो optic gliomas वाले होते हैं, they go into central precocious puberty. So the NF gene was positive. This is another child. अब इसमें थोड़ा सा आप लोग जरा concentrate करें. Increased penile length थी, while testicular volume was normal. According to the age, इसका तकरीबन 8 centimeters की stretch penile length थी, which is very length is quite high. Both testes were palpable in the scrotum and volume was 4 ml. बिल्कुल borderline था. यानी आप यहाँ मतलब like you concentrate that the almost normal testicular volume. So this was maybe peripheral precocious puberty or CH. उसको कोई salt losing crisis नहीं था. So this was a simple virilizing CAH, or it can be adrenal tumor. Premature adenarche is thoda sa out, the child was very young. अब इसमें देखें आप 17 OHP was 7, which was high. The LH FSH are remarkably low, less than 0.3 आप देख लें. and the testo is high, 25 higher side पे था जो labs की normal range थी, and ACTH was also high. So this was, again, we sent the genetics for this child, and he was homozygous for 11 beta 1, CYP11 beta 1 mutation, which is important cause of precocious puberty in boys, and 11 beta hydroxylase deficiency. He responded very well. काफी लंबे अरसे बाद इसका response आया, but he's doing well on his hydrocortisone. We are not giving him fluorinav because they are hypokalemic, और इनको फिर हमने spironolactone पे दोनों पे रखा था, and the child is doing well. So my key message is precocious puberty is becoming common, and हम लोग काफी देख रहे हैं cases, again due to genetics, due to endocrine disruptors बहुत बात हो रही है, lifestyle changes, but majority boys में ये abnormal होती है. So girls में sometimes there are normal variants also, and it raises a lot of concern in the parents. GnRH is the mainstay, gold standard in central precocious puberty, and aromatase inhibitor like anti-androgens and receptor modulators are effective in peripheral precocious puberty. Of course, CH में आपको glucocorticoids और mineralocorticoids देने हैं. It should be a, जैसे सर ने एक लिस्ट दिखाई थी, pediatric gastroendocrinologists, nurse, surgeons, and mental health counselors to improve our outcome. Of course, we will need our help of our adult endocrinologists also, क्योंकि उस patient को आगे transfer भी होना है और आगे जाकर so we need the patient, usually all the patients, all the children with precocious puberty need a psychological support also. बच्चे बहुत परेशान होते हैं कि मेरे साथ इतना जल्दी ये सब कुछ क्यों हो गया, especially girls. Sometimes they are crying कि हम इतनी जल्दी हमें, why we have menarche so early. So these are very normal things which we used to see in our practice also. So, but you need to give a lot of psychological supports to the children, to the parents also. And of course, you need to diagnose it properly, that there should not be any sinister pathology. These are my references. Thank you so much, and thank you for your kind attention.
Thank you, Dr. Mosana, for an excellent presentation. In fact, सारी presentations बहुत अच्छी थी. I have learned a lot. And in fact, आप सब ने भी यकीनन learn किया होगा. We have 10 minutes 10 minutes for question answer. If you have any question, please come forward. Excuse me. Mic.
Assalamualaikum. Indeed, we had like some really great talks today. So my question is from the panelists that if I see a patient, he's 10 years of age and he has micropenis. I've excluded all the hormonal causes. And it's just a simple micropenis. And you can see that within like 2-3 years, he is going to enter into puberty. So do I still need to treat him, like giving him a kick of testosterone, or I can reassure him that maybe in a couple of months or 1 or 2 years, he's going to catch up?
Mic to that.
Thank you. Thank you for the question. I think, देखें, एक तो बात इसमें clear आपने जो question में नहीं है, the micropenis is not simple, right? We have already said that you have to differentiate between a small penis and a micropenis. If you have a small penile size or a buried or the other variants that we have talked about, then you can reassure. Then you don't need to do anything. The child will probably go into puberty, and the penile size will come as he will hit puberty, so you can reassure the child and the parents. But if it's a micropenis, it gets a little tricky because technically you should treat micropenis. So you have to investigate first of all and find out why this child has got a micropenis. And if you find pathology, then you need to treat that. But if it's otherwise a small penile size and you don't think it fits into the definition or the criteria for the micropenis, then perhaps reassurance is what you need to do.
We have another question.
Assalamu alaikum. Prolonged untreated hypothyroidism leading to the precursor of puberty. Number one thing, okay, what will maybe the level of TSH may give rise to the precursor of puberty, as well as duration of the hypothyroidism. हमने जो लिटरेचर में पढ़े हैं prolonged untreated hypothyroidism may give rise to the precursor of puberty. इसमें जरा थोड़ा सा explain करें please. Thank you.
आपका सवाल ये है कि हाइपोथायरॉयडिज्म, मैं आ रही हूँ, यहीं रह रहा हूँ, ठीक, नहीं जज्बाती नहीं हो रहे। मुझे जरा सा सवाल रिपीट कर दें काइंडली। थायराइड हार्मोन का लेवल कितना होगा? देखिए, ड्यूरेशन, राइट, देयर इज नो स्पेसिफिक गाइडलाइन अबाउट द लेवल के TSH। अगर 50 होगा तो उसके ऊपर वो हो जाएगा। वी नो वेरी वेल कि उसका स्ट्रक्चर सिमिलर है, लेकिन यूजुअली जो केसेस हमने देखे हैं और जो आप लोगों ने रिपोर्ट भी किए हैं, दे हैव मोस्टली बीन मोर देन 100. It means that the hypothyroidism was very severe and was going on for a long period of time. How much time would it take? It usually is at least a period of more than 6 months, but many a times it's years that are required, because what happens is for that TSH to stimulate the ovaries and for the follicles or the cyst to develop and then cause the secretion, it takes some time. So the time period usually is more than 6 months, but many a times it's in years. No specific levels are reported in literature. ठीक?
So we have reported almost 15 cases from NICH, and that has published in JCPSP. And the children varied from like 10 years tak bhi unka hypothyroidism treat nahi hua. Like 8 years tak hypothyroidism, and they were congenital hypothyroids for long duration from 6 months to 5 years tak, 5-6 years per isolated menarche ke sath. Usually वो disconsonant सा कुछ होता है, like they are having the cycles but they are not having that much breast development, but sometimes the breast development is also there. So you cannot say कि किस time पर present कर जाएगा, as early as 6 months and as late as 4 or 5 years. So it varies. और दूसरा ये कि कोई लेवल का भी कोई कट ऑफ नहीं है. इट कैन बी अबव 50, इट कैन बी यूजुअली कट ऑफ 100 तक है जो लैब्स कर रही हैं. एंड इफ इट इज यूजुअली सिवियर हाइपोथायराइडिज्म होता है. इट्स नॉट दैट कि बॉर्डर लाइन हाई है, 10 से ऊपर है जरा सा, या 10 to 50 तक. इट्स सिवियर हाइपोथायराइडिज्म. मोर देन 100 का लेवल होता है TSH का, और T4 बहुत लो होता है. इवन मैं शेयर करना चाहूंगी, 21-year-old वेरी शॉर्ट गर्ल, cretin, and presented with cyclic bleeding and landed in gynae ward. And then we were contacted and she was hypothyroid. So we do see still cases with prolonged hypothyroidism and with the sign of isolated vaginal bleeding or menarche, whatever you want to say. And the treatment response is excellent.
Thank you. Actually, I have a question. I'm not, so that answer is, I think you have got too many answers for that. So I've got a question which I want to ask to the panelists and also some of the leading endocrinologists sitting here. So I would like to take their opinion also. And I don't know the answer. I'm not teasing anybody. I'm not sure what is the role of this endocrine disruptors. So do we have a scientific I mean, you know, it's a very common question. Doctor साहब, ये chicken में जो है वो हार्मोन होते हैं, बच्चों को खिलाएं ना खिलाएं, फला में होते हैं. So, you know, very commonly asked question. We know that there are endocrine disruptors which can affect, but do we have a scientific evidence to say something, or do we have anecdotal evidence? So I would like a couple of opinions on that. starting from the jump.
I mean, I think this is a developing field now. And now we are talking about endocrine disruptors. Evidence is coming, but evidence is not really definite at the moment. So we cannot be absolute on saying that this is the cause for this problem. Answer to ये कि the evidence is not there and we cannot say anything कि आप ये खाएं ये chicken ना खाएं और बकरे खाएं या सब्जी खाएं. अब ये बड़ा मुश्किल इसका I won't be able to give any real answers based on the science.
एक्सक्यूज मी, जब इडियोपैथिक क्लासिफाई हो जाएगा ना और उसके मसाइल हल हो जाएंगे तो ईडी आ जाएगा सामने.
I agree with Najmul Islam. I've got few comments. I congratulate Dr. Aisha Sheikh and Dr. Sumira Batul and team for organizing this type of seminar. Actually, there is need for combined pediatrics endocrinology and adult endocrinology, because in pediatric endocrinology, they not end. They will not end at the age of puberty. Puberty is transition between these three people, and we adult endocrinologist. So there should be a smooth transition from peds endocrinology, because these patients go to adult endocrinologist anyhow, because their problems will not end. The problem is pharmaceutical company, because this I am saying that they are involved in those diseases in which their drugs are sold. Obviously, there is a commercial reason. So for thyroid, there is no profit. Very cheap tablets, neomagazole, thyroxine. So I congratulate Pakistan Endocrine Society for organizing and emphasizing thyroid disorders as well, without the involvement of any pharmacological help or sponsorship. And there are so many problems, cretinism. Eventually, they will go to adult endocrinologist. They have to handle type 1 diabetes. And after puberty, metabolic syndrome occurs in type 1 diabetes. So they become obese. They might need metformin. It is known double diabetes. So there are more issues when these patients come to adult endocrinologist. Same applies to congenital adrenal hyperplasia, and we have to continue the medication after they become adult. So these are my few comments. And one thing I may emphasize: pedometer. Please use pedometer to assess the size of the testes, because I saw many family physicians, they are doing ultrasound of testes. Ultrasound is two-dimensional, and we need pedometer to mark from 1 to 25. So please use these gadgets if you are endocrinologist. Thank you.
Thank you, sir. I would request rest of the panelists to please comment on today's session.
I must thank you, Aisha, and the pediatric endocrinologist, adult PES, the Pakistan Endocrine Society, for taking us on board also, and organizing all these things. And I know that the pharmaceutical is also involved, so thank you to them also. They supported for this total, I think, educational event. And as sir has said, Dr. Zaman, no drugs are involved in it, but we need to study on, we need to learn these subjects also. These are very, very tricky and sometimes really perplexing for us also. So this is a really very good forum. Gynae ki bhi bahut se friends maujood hain. Thank you so much for being here and and being with us.
Yes, thank you. I reciprocate Mohsana's remarks. It was a good learning opportunity for me while organizing it along with Dr. Aisha. So thank you for giving me that chance. And we need more and more. And I'm so glad to see so many participants today, which is a Sunday, so early in the morning. So thank you everyone for being here, and thank you to PES and to Sami for supporting us.
I completely agree with what has been said, and thank you for the speakers for the excellent presentation, except myself. Sorry. Yeah, I would definitely second that we need, this is a very good beginning, but we need more sessions like this. We have informally talked about doing the transition medicine because, as Professor Zaman said, KG, lots of these endocrine problems will eventually go to the adults. So I think we need to maybe move a step forward and include the obstetrician and the gynecologist, because we do have a lot of commonality, especially when we talk about CAH, when we talk about pubertal issues in girls and other issues. So we can even include the OBGYN people in our sessions to get a more comprehensive and a holistic approach regarding the patient care. So thank you very much, PES. I'm also part of PES. I'll always be. And we really love to be here and be part of this session.
Thank you, sir. अस्सलाम वालेकुम एवरीवन. So आप लोग चाय लेके भी आगे आ सकते हैं. Let's start the second half of the session. प्लीज आप लोग सारे आ जाएं तो हम नेक्स्ट सेशन फिर स्टार्ट कर लें. So let me first introduce you to our panelists of this session. First of all, I would request Professor Dr. Tazeen. She is a well-reputed and an experienced gynecologist with more than 15 years of experience in her field. She is currently practicing at Abbasi Shaheed Hospital, Karachi. Thank you for joining us today. Our second panelist is Professor Dr. Najmul Islam. He is a professor of medicine and consultant endocrinologist at Aga Khan University Hospital, Karachi. He is an ex-president of Pakistan Endocrine Society and has a vast experience in managing endocrine disorders. He has a multiple publications in national and international journals. So our next panelist is Professor Dr. Saeed Meher. He is a professor of medicine and consultant endocrinologist, head of endocrine services at NICVD. He's a past president of Pakistan Endocrine Society and has also received a Lifetime Achievement Award for his services in the field of endocrinology by Pakistan Endocrine Society. Thank you for all the panelists for joining us today. So let's move on, and I will introduce you to our speaker. The talk she is going to deliver is about delayed puberty. Our speaker is Dr. Aisha Shea. She's a consultant endocrinologist at Aga Khan University Hospital and a current president of Pakistan Endocrine Society. She is also a registered tutor for the postgraduate teaching at University of South Wales, UK. She has a vast experience for managing endocrine disorder with a special interest in gestational diabetes and women health. Thank you.
Bismillahirrahmanirrahim. Assalatu wassalamu ala khataman nabiyyin. وعلى آله وصحبه أجمعين. Assalamu alaikum. I'm really grateful to all of you for your kind presence in today's session. Thank you, Dr. Sumaira Batul, for your kind introduction. And it's a huge pleasure to be part of this joint symposium between Pakistan Endocrine Society and Society of Pakistan Endocrine Pediatric Endocrinology and Diabetes, Pakistan. I would like to extend my thanks to Dr. Khadija Humayun for helping us and be an active part in all this series of webinars and symposium. And I would like to extend my thanks to Sami Pharmaceuticals for helping us with this full day symposium that is being held simultaneously in Islamabad, Peshawar, Lahore, and Karachi. And the Karachi symposium is actually being broadcasted to our Quetta colleagues as well. So I will just begin my talk on delayed puberty in girls. Okay, so just for those participants who have joined a little bit late, puberty production in girls, over here you can see that puberty starts sometime between 10 to 11 years. That is the average age of pubertal onset with the Tanner stage 2. At the same time, growth spurt would be occurring. And so over next 2.5 years, you will expect that the girl will start having her first menstrual period or the menarche, and that is between stage 4 and 5 breast development. And at the same time, as Dr. Khadija has already mentioned, the pubic hair stage or the adrenarche or pubarche actually follows thelarche. Thelarche is the breast bud, stage 2 of puberty. So you can see that there is a sequence of events that is taking place, a time lapse to menarche from if the girl is entering menarche, is starting her puberty at an earlier age, the time lapse to menarche would be longer compared to a girl that is having her thelarche later on. Over there, you will expect that she will have menarche earlier on. The duration would be lesser. So this is the time lapse. And then consonance of puberty is something that we all need to keep in mind, that there is a sequence or harmony or consonance, or as Dr. Mohsina said, कि एक नज्म है जिसके लिहाज से puberty progress करती है. Secondary sexual characteristics, starting with breast bud development or thelarche, followed by pubic hair growth acceleration, and then culminating into menarche. The absence of normal consonants actually suggests an endocrinopathy and requires investigations. So this is a case of 16-year-old girl. She's a student of class 10th who has recently recovered from GB syndrome and is referred for primary amenorrhea. Both of her sisters had menarche at age of 15 years, and in the examination, she has a weight of 55 kg, height is 145 cm. She reports a normal sense of smell, no axillary pubic hair, Tanner stage 1 breast. So you can see that, and genitourinary exam is prepubertal, normal female, and normal vaginal opening. So this is something she is pubertal stage 1 or actually Tanner stage 1 or prepubertal stage. And when you plot her growth and height on the growth chart, you can see that she's 16 years and she is 145 cm height, and this is her weight. So you can see that she is well below the 5th centile of height. So there is a short stature as well. And then certain tests were ordered which showed FSH of 0.5, LH of less than 0.2. And then you can again recall from talks by in the last session that 0.3 LH is something where you will say that maybe puberty has started. Her estradiol is low, and someone ordered a testosterone as well to look at any of the DSTs and other causes of her delayed puberty. And then because there was a hypogonadotropic hypogonadism picture, pituitary was further worked up, anterior pituitary function was further worked up, and you can see all those were normal. And so what is the diagnosis over here? You can see that this is short stature with delayed puberty and likely hypogonadotropic hypogonadism. But is it true hypog or something else? And then this girl gets lost to follow up and presents later on, and we'll see how the things progressed. Delayed puberty, as Dr. Khadija has already said in her talk, when we look at this Gaussian curve, any
a child that is actually falling 2 or 2.5 standard deviation from the mean, from that standard deviation will be labeled as having delayed puberty. So in girls, if there isn't a breast development started by the age of 13 years, this is labeled as delayed puberty, or if there's absence of menarche by age of 15 years, even if the breast development already occurred, this will be labeled as delayed puberty. Pubertal arrest is another thing that we need to keep in mind, is that it is defined as lack of pubertal progression for more than 2 years after spontaneous onset at the appropriate age. So the thelarchy started at the appropriate age, but the puberty did not progress further, so that girl did not start menstruation. Uh, Let us look at the hypothalamic pituitary gonadal axis. You can see that through hypothalamus, GnRH is released, which has effect on the pituitary gonadotropes. FSH and LH will that stimulate the gonads to release steroids and the ovum. When there is a problem with the ovary itself, it will lead to low sex steroids, so estradiol would be low. But at the same time, through the negative feedback effect on hypothalamic pituitary axis, there will be high LH and FSH levels. So this is hypergonadotropic hypogonadism. And then the other thing would be, if the hypothalamic and pituitary has a problem, the gonad itself is actually okay, but since there isn't a signal coming down from here, there is low LH-FSH leading to low sex steroids, and this is labeled as hypogonadotropic hypogonadism. When we come to delayed puberty etiology, constitutional delay in growth and puberty is something that we need to keep in mind. This is common, especially in boys. And it was interesting to see in Professor Jamal Razar's lecture on all those genetics that could be involved in CDGP as well. It becomes an important differential when you are having somebody with hypog, where there could be a primary problem with hypothalamic and pituitary. There could be functional causes like chronic illness, malnutrition. Think about all those malabsorption syndromes, excessive exercise that can lead to functional hypothalamic amenorrhea, and stress. All can lead to a picture of hypog. And if you correct this condition, this will spontaneously improve. And then the clinical biochemical presentation would be, like I earlier showed, low gonadal sex steroids along with low gonadotropin levels. The other would be primary gonadal failure, where there is a problem with the ovary itself, leading to high gonadotropes but low gonadal sex hormones. So this girl, which we are following, she presents after 1.5 years, and now she's 17 years and 11 months old. No menarche yet. She brings with her an ultrasound pelvis report which shows normal uterus, slightly smaller ovaries, 2 into 8.8 cm size. And on examination, now when you see her examination, you can see that this was her initial growth chart that we saw in the last slide. And now at this age, she is actually growing. You can see that her height has gone up by almost 5 cm or so. And this is her weight. And you can see that there is a little bit acanthosis nigricans as well. Pubic and axillary hair are now at stage 3, and breast is stage 4. So, and she did not receive any treatment. So what do you think she has got? So thank you. So this is what you label as idiopathic constitutional delay in growth and puberty. This is a variation of normal. And there would be a family history of late menarche and late puberty. Adrenarche especially can occur late. There would be retarded bone age as well. And these children usually enter puberty at bone age 12 to 14 years for boys and 11 to 13 years for girls. If spontaneous puberty does not occur by age 16 years in girls and 18 years in boys, permanent gonadotropin deficiency or primary gonadal failure should be considered. This is again, when you have hypergonadotropic hypogonadism, you can see that gonadotropins would be high, sex hormones would be low. For hypog, both will be low. I will not touch upon androgen insensitivity syndrome because that would be discussed in the next talk. And this is the analysis of a large cohort of delayed puberty. And you can see that in males, constitutional delay of growth and puberty is a very important cause of delayed puberty, while in girls, 30% can still be having constitutional delay followed by something like hypogonadotropic hypogonadism, hypergonadotropic hypogonadism, and other causes. When it comes to hypog etiology, CNS disorders like tumors can lead to a situation of hypog. Similarly, post-infection, trauma, radiotherapy, infiltrative disease, and most of you who are seeing children with thalassemia major would agree that they have because of their thalassemia and secondary hemosiderosis, they have this hypogonadotropic hypogonadism picture. Ask for symptoms and signs of increased intracranial pressure because if there's a tumor that is leading to these, and look for growth curve deviation, and that can be evident if a child is regularly falling with her or his pediatrician, and there's a growth chart available, and you can see that growth curve is now showing a deviation. The other could be typical syndromes like Kalman syndrome, which would be having anosmia or hyposmia, LHRH receptor mutations, DEX1 mutations, and then other transcription factor mutations that Dr. Mohsin has already pointed out in her talk. Similarly, the situation could be an isolated hypog or could be combined with other pituitary hormone deficiencies like again idiopathic and genetic mutations like PROP1 and HSX1, then Prader-Willi syndrome, Lawrence-Moon-Beadle syndrome, chronic diseases, malnutrition, and anorexia nervosa by leading to functional hypothalamic amenorrhea come under this etiology. And then hypergonadotropic hypogonadism, there could be chemotherapy radiation that led to ovarian failure or LH receptor defects, which are steroid biosynthesis defect, although more commonly described in boys than girls, and then Turner syndrome, which we time and again come across, and then XY and XX pure gonadal dysgenesis. So a Turner syndrome child would look like a webbed neck, low set ears, low hairline, increased carrying angles, you can see, and then short metatarsal and metacarpal bones. And these children have a picture of hypergonadotropic hypogonadism. When it comes to clinical evaluation of a girl with delayed puberty, history is always important. The family history of pubertal onset, and that will help us know that maybe there is a constitutional delay of growth and puberty. Then history suggesting chronic diseases, nutritional history involving anorexia nervosa, excessive energy utilization, vigorous exercise, athletes and ballet dancers. Similarly, delayed cognitive development with some dysmorphic syndrome, and history of any medication. So if the child had some kind of malignancy that she required chemotherapy, that would be important. On physical examination, height and weight, so always plot their height and weight on growth chart so that we know the growth velocity, and that is very helpful in identifying problems with growth and puberty. Longitudinal growth assessment is important, body proportions, physical signs suggestive of chronic diseases, malnutrition, dysmorphic syndromes, and sense of smell. With lab evaluation, the baseline would be obtaining gonadotropins and sex steroid levels. In cost-constrained settings, you can even suffice with FSH and estradiol to begin with. X-ray bone is something that is a necessity and is a must whenever you are having a child with any kind of pubertal disorder, may it be precocious or delayed puberty. An expert evaluation should be performed in any girl who does not show any sign of puberty by the age of 13 years. Any girl who by some definition has delayed puberty, that is the pubertal standard deviation score of less than -2, and all girls with a known condition or diagnosis that poses a risk of hypogonadism from the age of 8 years. So if you have a girl who already has received chemotherapy, then maybe you can start evaluating her earlier. But otherwise, in all others, if there is delayed puberty, no sign of puberty by the age of 13 years, that child deserves evaluation. The other studies, so initial assessment would be estradiol and LH, FSH levels, getting the thyroid function tested, because if especially we have seen in precocious puberty talks that hypothyroidism can lead to precocious puberty, but can lead to delayed puberty as well. We know that GnRH signals can be affected. Similarly, there could be hyperprolactinemia because of primary hypothyroidism that can lead to problems. Prolactin level on its own would be a very useful test, because if there is hyperprolactinemia and a prolactinoma, just managing that prolactinoma would lead the child to enter into spontaneous puberty. X-ray for bone age and test for olfaction, and then additional test studies based upon these workup would be required. So karyotype, if somebody is having hypergonadotropic hypogonadism, you would like to have their karyotype because you want to see whether there is Turner syndrome, Turner mosaic, similarly an XXXY DST, MRI pituitary with contrast enhancement. When there is the initial assessment is showing hypogonadotropic hypogonadism picture, you like to look at the MRI pituitary, maybe getting the olfactory placode visualization as well if you're suspecting Kalman syndrome. Pelvic ultrasound to look at the initial uterine, whether uterus is present and what kind of size the uterus is having. LRH, LHRH test or GNRH test that we have already um, heard in the last talks, but these are not available in Pakistan. Pattern of pulsatile LH secretions, visual acuity and visual fields in situation where there is a pituitary macroadenoma that is close to the optic chiasm or abetting the optic chiasm. So the additional test studies would actually be depending upon this initial assessment. You cannot offer each and every test to every child. Your additional studies would be tailored according to this workup. So the important thing, and I'm really happy that most of our gynae colleagues are here, our pediatric and adult endocrine colleagues are here, pubertal induction. So when there is a girl with delayed puberty, the aim of the pubertal induction is actually to allow development of secondary sexual characteristics, particularly breast development, allow the growth of the uterus to an adult size and shape, achieve a good adolescent growth spurt, achieve normal peak bone mass by late 20s, and support psychological maturation and adjustment. And to achieve these goals, as Dr. Jamal Raza has already pointed out, Dr. Khadija and Dr. Mohsina in their talks, you need actually a multidisciplinary team to manage such children. How is pubertal induction achieved? When we are doing pubertal induction, an appropriate estrogen replacement therapy, which would be mimicking the physiology and timing and pace, is the mainstay of pubertal induction. So we have seen how normal puberty is progressing from age 10 to 11 years to age 13 years, over a period of 2.5 years time, where the different stages of puberty are occurring. When we are replacing a child for pubertal induction, we have to mimic that normal physiology. And spontaneous puberty and treatable causes of hypogonadism should be ruled out before starting pubertal induction in girls. So we have already discussed all those causes in previous slides. Look for those treatable causes. And if we treat that cause, the girl would enter spontaneous puberty. But in all others, you will need to induce puberty. When should pubertal induction be offered? So it's recommended that to start individualized puberty induction in girls at the age of 11 years in cases where there are no signs of pubertal development and a diagnosis of hypogonadism is confirmed, or at the age of 13 years if constitutional delay is suspected. And then in order to imitate the natural dynamic of puberty advancement, an incremental increase in the dose is recommended over a period of 2 to 3 years. The best preparations are 17 beta estradiol based preparations. We do not have those available with us. Transdermal preparations are used for pubertal induction around the globe, but we still do not have transdermals in Pakistan. We have got oral preparations available to us. But if you look at the literature of whether one is has an edge over the other, the data suggests that the metabolic effects of transdermal and oral estrogens are similar across various endpoints, with evidence suggesting liver protection from estradiol supplementation and inconsistent effects on IGF-1 levels. The transdermal estrogens show less bone age advancement and faster spine bone accrual compared to oral forms. With estrogens, the long-term breast cancer risk, especially studied in Turner syndrome, remains lower in control. So you might come across patients whose parents are worried about any risk of breast cancer with estrogen replacement. No such risk is actually reported in studies, and actually the risk is lower than the control population. These are the estrogen preparations available in Pakistan. I deliberately did not mention other preparations that are available globally because in practical sense, that won't be of any use for us if those are not available to us. So what we have got is estradiol valerate, which is available by the name of Progainova alone. Although globally, these are the doses 0.5124 available, but in Pakistan, we only have got 2 milligram dose. And then we have got the conjugated equine estrogens preparations available by the name of Primarin in 0.625 dose. And there's another one by the name of Minorin, which is 0.3 milligram dose. And now let's see how we induce puberty using these conjugated equine estrogen preparations, Primarin or Minorin. So if you're using the 0.625 milligram tablet and considering the child is Tanner 1, that is pre-pubertal, you will be starting with half tablet alternate days for 6 months. And then you'll keep on escalating doses. So alternate days, 6 months, then half tablet daily for another 6 months, then 1 tablet daily for 6 months, then 2 tablets daily, which will equate to 1.25 milligram dose for 6 months, and then 3 tablets daily for another 6 months, and 4 tablets daily, that is 2.5 milligram for 6 months. So that is a duration of 3 years time where you are um, uh, letting the child undergo pubertal progression. The other version that we have available with us is estradiol valerate, which is by the name of Progainova. Again, as I already told that this is in 2 milligram doses available. Uh, Again, so you consider Primarin and Progainova. Progainova 2 milligram equivalent to Primarin 0.625 milligram. You start with something like alternate day for 6 months, then half tablet daily for 6 months, then 1 tablet daily for 6 months, then keep on increasing till 4 tablets daily, that is 8 milligram for 6 months. So again, this is a 3-year period time where you are letting the child go through pubertal progression. What monitoring is needed during these pubertal induction regimes? So pre-puberty, during puberty and post-puberty, measure their blood pressure and height velocity. And post-puberty, you will continue to measure their height till a height velocity of less than 2 centimeter per year, which means that a child has now attained the full adult height. The pubertal staging should be done pre-puberty and during puberty. Pelvic ultrasound at baseline, pre-puberty, and then post-puberty, because you want to document uterine size and shape, and that has relevance for future fertility options as well. Bone age in the pre-puberty and then during puberty every 6 to 12 monthly. You are falling during puberty every 6 monthly, but you're doing their bone ages annually. You do not need to do the bone age in the post-pubertal period though. And bone density scan that is something which is recommended 1 year post menarche. In case of low BMD, or if the girl is non-compliant to her hormone replacement, you can repeat it in 3 to 5 years. When to add progestin? So remember, the family might be worried that my child is not having her periods. Our aim is to induce puberty in a natural, normal, physiological manner. So progesterones, when we add progesterones, it means that breast development and uterine development will not occur any further. So we have to be sure when are we going to add progesterones in a way that we are not impacting adversely the child's breast development or the uterine maturation. So it is added, progesterones are added after puberty induction or during sex hormone replacement to sustain puberty in girls after breakthrough bleeding, after at least 2 years of treatment. So if at least 2 years have elapsed since you started her on estrogen replacements, then you can consider progesterones. Progesterone should be added after optimal breast and uterine maturation, either at the first breakthrough bleeding or 2 years after starting the estrogen therapy. A 10-day cyclic treatment is preferred with options including oral micronized progesterones. So these are available in Pakistan, progesterones 100 or 200 milligram doses. Dydrogesterone is also available in Pakistan. Medroxyprogesterone is not available but can be imported. The simple one is norethistérone, which is easily available in Pakistan, which is Primonute. And so when to switch to adult hormone replacement? change pubertal induction treatment of estrogen and progesterones to permanent adult sex hormone replacement therapy and at the end of pubertal induction. So now you have gone through the pubertal induction process and the child has attained puberty. Now you can think about switching to adult hormone replacement. In these the cyclical regime, so we at our clinical practice prefer these cyclical regimes where we give them estrogens either through estradiol valerate or conjugated equine estrogens day 1 to 25, and these are the calendar days. So we tell our patients जिस दिन first तारीख हो पहली तारीख वहां से आपने लेना शुरू करना है 25 तारीख तक, and then you will add progesterones by either Primulute N twice daily or Defeston last 10 days, day 16 to 25, and on day 25 they stop both these pills and she will get her withdrawal bleed, and then she resumes estrogens from calendar date 1 of the next month. The alternative, so few girls might find it difficult to follow the cyclical regime. There were problems of availability of hormones off and on, especially during pandemic. Most of you who are using these hormones for a patient would recall that during pandemic there was a problem with availability of these hormones. Alternatives could be the combined hormonal pills, which are based upon estradiol valerate preparation. Progyliton or estranon, both of these have 2 milligram of estradiol valerate in their regime. And the less attractive option would be using a combined oral contraceptive pills, because we have those low dose pills available. Generally, we do not have full dose contraceptive pills available mostly. And we want, so these girls who are actually hormone deficient, you want them to have good estrogens for replacement. So when we're using the cyclical regimes, we prefer using either 0.625 milligram of conjugated equine estrogens or 1.25 milligram daily when they're adults, or estradiol valerate 2 milligram or 4 milligram doses estrogens in these cyclical regimes. What about if a girl is already presenting to a recommended that a faster than normal increase in estrogen doses can be considered in such cases. And okay, so this is, I think it's, yeah, you can see it. So delayed puberty, I just like to sum it up. Initial evaluation includes previous growth pattern, nutrition status, evidence of anorexia, and intensity of athletic training, past history of chronic disease, psychosocial function, radio chemotherapy, family history of age of pubertal onset, history of infertility, midline abnormalities of family members. Physical exam would include growth rate, Tanner staging, midline abnormalities, anosmia, biochemistry and bone age, basal LH-FSH, IGF-1 and prolactin can be considered in individualized basis. So if there is low or normal LH-FSH for early Tanner stage, normal growth rate for bone age, this could be GnRH deficiency or self-limiting, delayed puberty, where you will offer GnRH test, ACG stimulation test, serum inhibin B, olfactory function test, and genetic testing. If there is a slow growth for bone age in somebody who is hypog, this could be functional hypogonadotropic hypogonadism. If there's low BMI, GI disorders and underfeeding could be evaluated. And if there's normal BMI, think about thyroid dysfunction, and similarly hyperprolactinemia and growth hormone deficiency. For high BMI, think about any steroid intake by the child, and examine further for chronic disease and consider growth hormone provocative test over here. Similarly, if there is elevated FSH, so the child is having hypergonadotropic hypogonadism or primary hypogonadism, karyotyping is something that is required. Again, the simple algorithm would be LH-FSH measurement. If there's low, this is central. Think about constitutional delay of growth and puberty, and hypothalamic pituitary causes. If LH-FSH is high, this is hypergonadotropic hypogonadism, and gonadal failure should be kept in mind. So this is my take-home message. Delayed puberty in girls require careful evaluation to determine the underlying cause. Early diagnosis and appropriate treatment are essential to ensure optimal growth, development, and psychosocial well-being. Hormonal therapies for pubertal induction should mimic the normal physiology of puberty, completing the process over 2 to 3 years. And for this, it is important to counsel the patient and the family. They should not be expecting a miracle to happen that today the child is prepubertal and within a month she will be having 10 or 4 breast and menarche being started. So the expectations should be realistic. Fertility, I on purpose did not touch upon fertility because of the limitation of time. But remember, people with hypog can have fertility treatments which will have them have their progeny. But those who have hypogonitropic hypogonadism, have ovarian failures, they can undergo either ovum donation or adoption kind of things. So these things can be discussed in a culturally sensitive manner to the child and the family. Maybe the family would be better able to understand rather than the patient herself. And I'll take an opportunity to invite all of you to our upcoming annual conference, 22nd annual conference, planned to be held at Lahore just 2 weeks from now. An open invitation to all of you. So thank you very much for your patient listening.
Thank you, Dr. Aisha, for such a comprehensive presentation. Our next topic is delayed puberty in boys. And for this, I would like to invite Dr. Awais Rashid. He's a consultant endocrinologist at Liaquat National Hospital, Karachi, and a visiting faculty at Aga Khan Hospital. He has a keen interest in research with multiple publications in national and international journals. Thank you, Dr. Awais.
Assalamu alaikum. I'm Dr. Oves. Thank you, Sumera, and thank you, PES, for inviting me for this talk. I am an adult endocrinologist, so I will be discussing a topic that is mostly seen by pediatric endocrinologists, and we get to see patients late, I mean, around 18, after 18 years of age. But I'll try to do it as good as I can. So this is the outline of my presentation, and I will be discussing about how to identify and correctly diagnose different causes of delayed puberty, recommend the most appropriate test for diagnosing various causes, and discuss management of patient with different etiologies of male delayed puberty. So we are all aware that puberty starts whenever there is pulsatile increase in GnRH from the hypothalamus, and which in turn stimulates the anterior pituitary gland to start secreting gonadotropins. These gonadotropins then stimulate the gonads, testes, to start initiating the synthesis of testosterone and start spermatogenesis. So the average age of onset of puberty, we all know that, is later in males as compared to females. It is around 12 years. And this average age of onset of puberty varies because of number of historical factors, genetic factors, ethnicity of an individual, and weight change that an individual is likely to have during or around the years of puberty. So we all know that gonadarchy is the first sign of puberty. Enlargement of breast in females or enlargement of testes in male is the first sign of puberty, but adrenarche or pubarchy occurs around 2 years prior to gonadarchy. And this adrenarche is because of maturation of the zona reticularis of adrenal cortex, and this results in increase in the adrenal androgens, resulting in pubarchy. But this does not activate hypothalamic pituitary gonadal axis. Rather, it's the GnRH and then the gonadotrophins that stimulate the gonads to start secreting testosterone or estrogen, resulting in testicular enlargement or breast enlargement in females. So what is delayed puberty? In easier words, if the puberty does not start after 14 years of age in males, it is termed as delayed puberty, and it is absence, either complete or partial absence of sexual maturation above the mean age of onset of puberty. And approximately 95% of individuals, or around 97% of individuals, complete their pubertal development within 4 or 5 years of the start of puberty. And one of the definition of delayed puberty or stalled puberty is that if they are unable to complete this pubertal development, then it is also regarded as delayed puberty. So the causes of delayed puberty, as Madam was already described, are quite similar in both males and females, apart from some syndromic causes and congenital causes. Constitutional delay of growth and puberty is the most common cause of delayed puberty, especially in males, whereas hypogonadotrophic hypogonadism, which can be functional, or hypogonadotrophic hypogonadism due to congenital cause or structural cause, is the next most common cause of delayed puberty. Then there is hypergonadotrophic hypogonadism, primary hypogonadism, and other unclassified or idiopathic causes of delayed puberty. So if there is problem within the gonads testis, then it is primary hypogonadism, and this is characterized by increase in gonadotropins, both LH, FSH, and decreased testosterone. Whereas if the problem is in the anterior pituitary or hypothalamus, it is secondary or tertiary hypogonadism with low gonadotropins and low testosterone. So in central hypogonadotrophic hypogonadism or secondary hypogonadotrophic hypogonadism, the gonadotrophins would be low with low fasting early morning testosterone levels, and at times gonadotrophins can be inappropriately normal, especially if there are structural causes of hypogonadotrophic hypogonadism. The hypogonadotrophic hypogonadism can be further divided into functional and permanent. Functional causes of hypogonadotrophic hypogonadism are generally reversible, are secondary to other causes, whereas permanent causes are due to impairment of hypothalamic pituitary axis, which can be because of congenital or structural causes of hypogonadotrophic hypogonadism. So coming to the functional impairment or functional causes of hypogonadotrophic hypogonadism, constitutional delay of growth and puberty is the most common cause of hypogonadotrophic hypogonadism, which is then followed by untreated, unrecognized chronic diseases. And once we start treating these diseases such as celiac disease, severe anemia, iron deficiency anemia, thalassemia, then there are chances of growth and puberty in these individuals. Then this is followed by poor nutritional, psychosocial deprivation, anorexia nervosa, severe weight loss, or anabolic steroid therapy, use of opioids. Hypothyroidism can cause both precocious puberty as well as delayed puberty because of suppression of gonadotrophin releasing hormone, resulting in suppression of gonadotrophins. Similarly, hyperprolactinemia can do the same. And then there are syndromic causes with Prader-Willi, Lawrence Moon, Bardet-Biedl, Char syndrome, which also result in functional hypogonadotrophic hypogonadism. But these patients have characteristic dysmorphic features with obesity and finger abnormalities and other abnormalities. So constitutional delay of growth and puberty is by far the most common cause of delayed puberty, especially in males, with male to female ratio of around 7:1. It is due to transient or dysfunction of the gonadotropin releasing hormone from the hypothalamus, and can be because of number of genetic and other reasons. At times, these reasons are not understood properly. It's a diagnosis of exclusion. These individuals have decreased growth velocity by starting from the age 2 to 3 years of age. Then they progressed, and then it goes through the childhood slowly, and their poor growth is especially noticeable around 9 to 11 years of age. Then these individuals slowly progress through puberty, but this pubertal development occurs before the 18 years of age. They have very characteristic family history of constitution of delayed puberty and growth in the family, with parents having the same history or sibling having the same history, but its presence or absence does not confirm or refute the diagnosis. Congenital hypo should be suspected if no signs of pubertal development after 18 years of age. Generally, constitutional individual with constitutional delay of growth and puberty complete their pubertal development or start their pubertal development prior to 18 years of age, before 18 years of age. But if there is failure to enter into puberty after 18 years of age, then congenital hypo should be suspected. Then there are permanent causes of gonadotrophic hypogonadism, and the important ones are those which are congenital, because generally they are irreversible causes. They include well-known Kalman syndrome, in which there is disordered migration of GnRH neurons to the olfactory bulb. Patient may have loss of sense of smell. There are normosmic variant as well, in which there is the sense of smell is intact. Then there are many genetic causes with isolated gene issues and other genes. Then congenital adrenal hyperplasia, in which there is, because of DEX1 gene mutation, there is primary adrenal failure as well as hypogonadotrophic hypogonadism. These are the permanent or congenital causes of hypogonadotrophic hypogonadism. Then structural causes include tumors, and among the tumors, craniopharyngiomas are most common causes of hypogonadotrophic hypogonadism in childhood, whereas among pituitary adenomas, prolactinomas are the commonest cause of pituitary structural causes of hypogonadotrophic hypogonadism in adult. Then there are infiltrative disorders such as sarcoidosis, hemochromatosis, head trauma, pituitary surgery, or radiation can also result in hypogonadotrophic hypogonadism. So this is a table which is showing the differentiation between constitutional delay of growth and puberty and congenital hypogonadotrophic hypogonadism. These are the two important causes, and at times it is difficult to distinguish between these two in boys between 14 to 18 years of age. After 18 years of age, congenital hypo is more likely. So we can see that boys who have got CDGP have got delay in growth and puberty, whereas boys with congenital hypo have delayed puberty only, and the growth is more than expected for the age. Then there is a strong family history of constitutional delay of growth and puberty in whereas in congenital hypo not that strong history is there. And individuals with congenital hypo usually have micropenis, cryptorchidism, and midline defects with cleft lip, cleft palate, cerebellar ataxia, neuroskeletal abnormalities are absent in CDGP individuals. Their height velocity in both are normal, but the bone age is delayed in individuals with IHH, hypogonadotrophic hypogonadism, whereas bone age is slightly delayed in CDGP, but the bone age corresponds to that of height age in individual with CDGP. And the final adult height is greater in IHH, whereas final adult height on growth chart is for CDGP is within the range for target height. So it is important to differentiate between these two when dealing with hypogonadotrophic hypogonadism, especially in individuals who are 14 to 18 years of age. Then there are peripheral causes of hypergonadotrophic hypogonadism, which is due to testicular failure, gonadal failure, and there is low 8 to 9 a.m. morning testosterone with high gonadotrophin level. So genetic Klinefelter syndrome is the most common genetic cause of primary hypogonadism, congenital cause of primary hypogonadism in males. Other causes include number of chromosomal abnormalities with mixed gonadal dysgenesis, Y chromosome microdeletion, and other syndromic causes. Then cryptorchidism, orchitis, chemotherapy, radiation, chronic illness, and testicular trauma all can lead to gonadal failure, which can result in hypergonadotrophic hypogonadism and delayed puberty in males. So it is important to take good history when evaluating individual with when evaluating male with delayed puberty. So what to ask? Is pubertal development totally absent, or did it start and then it got stalled or stopped for a while? Does the patient have nutritional habits? Is the patient nutritionally sound or not? Or is there any medical illness, chronic illness like untreated asthma or uncontrolled asthma, diabetes, celiac disease, any other chronic illness that may be resulting in functional hypogonadotrophic hypogonadism and delayed puberties? Then, does the patient have any congenital abnormalities or neurologic symptoms like in syndromic forms of hypogonadotrophic hypogonadism or Klinefelter or in Kalman syndrome? Is there family history of delayed puberty or absent puberty, which may suggest constitutional delay of growth and puberty? Does the patient have normal sense of smell for Kalman syndrome? So what to examine? It is important to measure the height of patient and parents and try to plot it on a growth chart, and also to derive mid-parental height or target height of the individual. It is important to see the BMI, whether the BMI of individual is low BMI or it is or whether the individual is overweight or obese or normal BMI, as chronic illnesses, psychosocial or anorexia nervosa or other illnesses can result in functional hypogonadotrophic hypogonadism. Physical examination should target chronic diseases or dysmorphic features, and abnormal neurological examination, if found, may suggest Klinefelter or Kalman syndrome or other syndromic forms of hypogonadotrophic hypogonadism. Then one should try to try to do Tanner staging of individual pubertal, testicular, and axillary Tanner staging should be done. Then micropenis and cryptorchidism may indicate congenital gonadotrophin deficiency. Similarly, anosmia, lack of sense of smell, may indicate Kalman or Char syndrome. So this is the orchidometer with which the testicular volume can be measured, and you can see pre-pubertally the testes are less than 2 to 4 ml, and once the puberty starts, testicular size increases above to more than 4 ml. At Tanner stage 2, it is 4 ml. At Tanner stage 3, it is around 8 to 10 ml. And stage 4 is around 12 to 15 ml. And adult size testis is more than 15 ml. So what investigation should be advised when when seeing a patient with delayed puberty and male? So CBC should be performed to look out for anemia, iron deficiency anemia, mixed anemia, or any form of anemia. Similarly, liver function, renal function, celiac antibodies should be performed to rule out any chronic disease, untreated, unrecognized diseases, and if treated properly, these individuals tend to catch up their growth and puberty. Similarly, gonadotropin should be checked, and early morning fasting testosterone should be checked. And if multiple pituitary hormone deficiency, growth hormone deficiency is suspected, and individual has severe delayed bone age, then growth hormone IGF-1 should be performed as well. Thyroid function should be checked, as untreated primary hypothyroidism, not subclinical hypothyroidism, may result in delayed puberty. Bone age should be checked, and one should look for epiphyseal whether the epiphyses have closed or not. And in constitutional delay of growth and puberty, there is bone age delay of around 1 to 2 years, but the bone age corresponds to the height age, whereas in hypogonadotrophic hypogonadism, bone age is delayed, and the individual tends to have greater height, and this is because of absence of uh, uh, testosterone from the testes. Then IGF-1 may be low for age, but not for bone age pubertal stage. Prolactin should be checked to rule out hyperprolactinemia if there is if the individual has if the individual is suspected to have multiple pituitary hormone deficiency, or if the individual has got signs and symptoms of hyperprolactinemia. Similarly, dynamic function testing, gonadotropin releasing hormone testing, or HCG stimulation testing should be performed to differentiate between CDGP and IHH, especially in individuals who are 14 to 18 years of age and not after 18 years of age. If indicated, MRI brain or MRI of the pituitary gland should be performed to look for the intracranial lesion, and in hypergonadotrophic hypogonadism, karyotyping should be performed to look for Klinefelter syndrome. So this is a diagram which is showing how gonadotropin releasing hormone and HCG stimulation testing in individual to differentiate, in a boy to differentiate between CDGP and IHH, especially those between 14 to 18 years of age. And with the newer assays, the need for these dynamic testing is lesser now, since the advent of newer assays for testosterone as well as for the LH. And you can see if the basal testosterone is more than 1.7 nanomole per liter, then it is likely the individual is likely to have CDGP. But if the testosterone level is less than 1.7, then one should proceed to basal LH level. If the basal LH level is more than 0.3, then the positive predictive value is around 100% for CDGP with newer assays. But if it is less than 0.3, then one should proceed to GnRH stimulation testing with triptorelin, which is a short-acting GnRH analog. So if after triptorelin, LH increases to more than 14, then the individual is likely to have CDGP. But if it does not increases beyond 14, then HCG stimulation testing should be done. HCG would stimulate the Leydig cell of the testis and stimulate the increase in testosterone. So if the testosterone level goes above 9 nanomole per liter, then the individual is likely to have CDGP. Whereas if the testosterone levels remains below 3, the individual is likely to have hypogonadotrophic hypogonadism. But if the levels remain between the two, then one should try to induce puberty and follow the patient and see the sexual maturation growth. And after stopping, if the individual enters into puberty, then the individual will be having CDGP. But if does not happen after 1 year of treatment with low dose testosterone, then the likelihood of hypogonadotrophic hypogonadism is greater. So how to manage patient with boys who have got delayed puberty? Patient-specific cause of delayed puberty should be treated. Functional causes should be treated. And underlying hypothyroidism, hyperprolactinemia, chronic diseases should be treated appropriately. and these individual tend to have normal puberty if this is done. For constitutional delay of growth and puberty, reassurance and support is only the treatment that can be offered. But if a child has got severe psychosocial problems with the height, then one can try to induce puberty with low dose testosterone. So 50 milligram of testosterone intramuscularly can be given to this child, this boy, and the patient should be followed every month or 3 monthly for growth maturation, sexual maturation, and virilization. With this therapy, there is increase in testicular volume by 3 to 4 ml in 6 to 9 months and progressive appearance of secondary sexual characteristic and acceleration of growth velocity from 4 centimeter per year to 9 to 10 centimeter per year. And the increase in testicular volume during low-dose testosterone therapy is attributed to an increase in FSH secretion by low-dose testosterone. So how to induce puberty and fertility in individual who have got hypogonadotrophic hypogonadism or primary hypogonadism? These individuals, taking into account family timings and psychological maturity. So the treatment modalities for induction of puberty, especially in IHH, include pulsatile GnRH therapy, HCG with or without FSH, and androgen replacement therapy with testosterone. But each of these therapy has got pros and cons. So GnRH is the only most physiological way to induce puberty, and it results in virilization, testicular development, and spermatogenesis. It is administered in a pulsatile manner via IV pump or subcutaneous pump, but therapy is very expensive, it is not available, and it is very, very cumbersome. Even in the best centers in the world, it is available with difficulty. So then how to induce puberty with gonadotrophins, HCG with or without FSH? HCG stimulates Leydig cells to produce testosterone, promoting virilization. HCG stimulates testicular growth, resulting in virilization and spermatogenesis in 20 to 30% individuals, particularly in those with evidence of endogenous FSH secretion, uh, especially in those with testicular volume more than 4 ml. If the testicular volume is less than 4 ml, then the chances of inducing fertility with HCG would be chances of inducing virilization would be lower in these individuals. Therapy with HCG results in stable testosterone levels as compared to exogenous testosterone levels because of regulated production of testosterone by Leydig cells. If we give testosterone injection, then the levels fall and rise. But with HCG, the level remain stable because there is regulated increase in testosterone by the Leydig cells. So the starting dose would be 500 international units. It can be increased to 2000 international units subcutaneously or intramuscular twice or thrice per week with an aim to maintain testosterone in the mid-normal reference range. The dose can be increased to 5000 international unit twice or thrice weekly, but when the testosterone levels are maintained, it should not be increased. The testosterone levels are maintained in the mid-normal reference range. It should not be increased, but as the child grows and the boy and becomes an adult, the adult dose is usually 5000 international unit twice or thrice per week. So FSH in induction of puberty in IHH, patient with complete deficiency of gonadotrophin as evidenced by testicular size less than 4 ml should be treated with HCG along with FSH. The dose is 75 international unit 2 to 3 times per week. Once testosterone maintained with HCG in the mid-normal range, it can be increased to 300 international unit 2 to 3 times per week, but this dose is usually for adults. So what are the predictor of response to gonadotropin therapy in IHH? Testicular volume is a very important predictor of response to gonadotropin therapy in IHH in males. If the testicular size is greater than 4 ml, then the individual is likely to respond better as compared to those boys who have got testicular size less than 4 ml. Absence of cryptorchidism or micropenis, which can be seen in Kallmann syndrome, and early initiation of gonadotrophins. Testosterone therapy suppresses spermatogenesis. This is because intratesticular testosterone cannot be maintained with exogenous testosterone. But with HCG, Leydig cells are stimulated and spermatogenesis can be achieved in 20 to 30% of individuals who have got testicular size greater than 4 ml. But therapy with HCG is expensive, requires frequent injection, daily injection, weekly injection, and it can result in greater gynecomastia as compared to testosterone therapy because intratesticular aromatization as well as peripheral aromatization of testosterone occurs to estradiol, whereas with testosterone therapy, only peripheral aromatization occurs. So it can result in greater gynecomastia in males. Similarly, there can be development of anti-HCG antibodies. So what are the aims of androgen replacement therapy, which is very commonly used? It is cheap, inexpensive, and easily available. The treatment aim is to improve libido, sexual function, growth of an individual, sexual maturity of individual, to improve mood and well-being, to improve muscle mass and strength, and to prevent osteoporosis, especially in individuals who have got congenital forms of hypogonadism, such as Klinefelters, such as Kallmann syndrome, and other forms. So this is a slide which is showing number of preparations of testosterone that are available, but the most commonly used preparation is intramuscular form. It is easily available, very cheap, and it has to be taken monthly or fortnightly. So the initial starting dose is 15 milligrams, and then the dose can be increased after 3 to 6 months, depending upon the sexual maturity, growth of an individual. And the adult dose is usually 250 milligrams, 2 to 4 twice weekly, or a monthly dose is usually given. The patient should be monitored for sexual maturity, virilization, and change in body habitus. Similarly, testosterone gels are also available. These result in more physiological levels of testosterone, but they are not available easily in Pakistan, and we do not use them very often. They are available as 10 milligram transdermal gels. They can be applied once daily, and side effects include allergic reactions or person-to-person contact can happen. So treatment schedule for individual for testosterone for induction of puberty include long-acting testosterone esters are available. Initial monthly 50 milligram injection should be taken for 6 months. Then the dose can be increased every 3 to 6 monthly to 75 milligrams, then 100 milligrams, and the adult dose is usually 200 to 250 milligrams, 2 to 4 times per week. And the testosterone level should be checked, and one should try to maintain testosterone levels in the mid-normal reference range. Peak levels of testosterone should be checked after 10 to 14 days to decide about the dose, and the trough level should be checked prior to injection to decide about the frequency of dosing. So once that androgen replacement therapy is started, one should try to monitor an adult dose is achieved. One should try to monitor testosterone level every 3 monthly, then 6 to 12 monthly. And the clinical evaluation should include relief of symptoms of androgen deficiency, excluding side effects, testosterone trough levels prior to new injection should be checked to decide about the frequency of dosing. And if the individual is on long-term, lifelong testosterone replacement therapy, especially in congenital forms, then rectal examination for prostate hypertrophy should be performed if individual is more than 40 years of age. PSA levels if individual is more than 40 years of age, because testosterone stimulates the growth of prostatic tissue after 40 years of age, generally after 40 years of age. Then hemoglobin hematocrit should be checked. And if the individual develops polycythemia, then the dose should be reduced and the frequency of dosing can be increased as well. Similarly, it may result in dyslipidemia, so serum lipids should be monitored after long-term testosterone therapy. Thank you very much.
Thank you, Dr. Vaz, for such a comprehensive presentation. So our third speaker is Dr. Ifat Ahmed. She is an assistant professor in the Department of Obstetrics and Gynecology of Aga Khan University Hospital. She has done her fellowship in Peds and Adolescent Gynae from Malaysia, and she has got Collaborative Award for Teaching in 2023, Award of Clinical Teaching in 2021, and Faculty Development Award in 2018. She is going to talk about primary amenorrhea.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Dr. Aisha and Pakistan Endocrine Society for inviting me today to this very knowledgeable and important session. And I think this is the need of the time for being multidisciplinary. My today's topic is primary amenorrhea, and mainly presenting as a sign of Mullerian anomalies. So when I was preparing for this presentation, I remember my very first presentation as a second-year resident. It was on primary amenorrhea, and out of all my storage, I found this presentation. And I remember how confident I was on that day that I know each and everything about primary amenorrhea. And now today, as I'm standing in front of you, I know I'm so humbled that how little I know and how little I can express in the next 20 minutes. So let's go. I try to be very to the point because we'll be discussing. Oh, so this is my disclaimer. So we'll be focusing more on the salient features of history and relevant examination related to Mullerian anomalies. Okay, so primary amenorrhea, we have different definitions. In OBS and gynae, we use normally 14 years and 16 years with and without secondary sexual characteristics. And actually, this is one of the very differentiating point between the physiological primary amenorrhea and anatomical primary amenorrhea. So yes, so around 40% of the cases of primary amenorrhea are due to the endocrine causes, while rest 60% are mainly due to anatomical causes or the Mullerian anomalies. So primary amenorrhea has severe, we all know, health implications on the later life of a girl. Multidisciplinary team, as I already mentioned, is very important nowadays. And since always it's important, but now we are learning that it's very important to work together. So something new is genetic testing, which is evaluating and is helping us more in understanding these things. We have been discussing since this morning on this HP ovary all the time. So we discussed the upper part, but I'm starting from the lower part of genital tract, starting from the hymen, vaginal agenesis, cervical agenesis, and anomalies of uterus. We are not discussing pregnancy here, but yes, pregnancy could be one of the presenting feature of primary amenorrhea. And for ovaries, we will be discussing mainly the gonadal dysgenesis. So this is my very favorite algorithm to diagnose primary amenorrhea, and I always teach my resident through it that we need to go through history and examination, and we have discussed history points in such a detail since this morning that I'm skipping that part and also for the examination. But the most important part I want to emphasize is secondary sexual characteristics, whether present or absent. Normally, the part I'm discussing, we used to have secondary sexual characteristics. For girls, obviously, the breast and the pubic hair. So Tanner staging is very important. The second important thing I want to emphasize is the presence or absence of uterus. So as far as the presence of uterus is concerned, we'll be dealing with the outflow tract obstruction, including imperforate hymen, vaginal septum, or vaginal atresias. Okay, so this was a very complicated classification of Müllerian anomalies, which is suggested by European Society of Human Reproduction and Embryology and European Society of Gynae Endoscopy. Yes. So, but American Society of Reproductive Medicine has simplified it and divided into uterine and cervical and vaginal things separately. So when we just quickly revise the development of female genital tract, we know that till week 7, the gonads are indifferentiate, and we'll be more interested in the paramesonephric duct or the Müllerian duct, the green one. So they both from each side unite here and form the uterus, the fallopian tubes, uterus, upper part of vagina, and certain other adnexal structures. So mainly focusing on the tubes of vagina, both these tubes unite here, and gradually the septum disappears. While for the vagina, the upper part is coming from the Müllerian duct and the lower part is from the vaginal plate or sinovaginal bulb. And later at the time of birth, it canalizes. Okay, so as far as the vertical fusion defects are concerned, we have starting from below the imperforate hymen and then vaginal septum, which could be a lower one, middle, or the upper vaginal septum. So imperforate hymen presents with amenorrhea, typically with cyclical abdominal pain. They have well-developed secondary sexual characteristics. And it actually presents with hematocolpus and plus or minus hematometra. So similarly with vaginal septum, they also present with the same or similar features, as I must say. And you can imagine that lower the obstruction, the more would be the hematocolpus. So hematocolpus is the collection of blood in the vagina, and hematometra is collection of blood in the uterus. And with the elasticity of vaginal wall, it can accommodate a lot more blood into it rather than more constricted uterine walls. So the lower the obstruction, the delay would be the presentation, because symptoms may appear little late, especially when it start accumulating in the uterus. So cyclical abdominal pain will gradually increase. While if the septum is higher up, it might present early because of the stretching of uterine muscles. Okay, so, and sometimes they present together as well. Okay, so these are some pictures I found on internet. So how to differentiate between imperforate hymen and transverse vaginal septums? So imperforate hymen would be lower at introitus. It's bluish membrane bulging out of os, and hematocolpus would be more than the hematometra. While in vaginal septum, it depends at the level of vaginal septum. If it's low or high, the bulge may not be present, but the blockage is more pinkish and thickened. Hematocolpus and hematometra both would be present, again, depending on the level. And you can see hymen remnants in front of the septum. So on imaging, this is the MRI pictures. So we can see that it's going right up to the introitus. Or यहाँ पे भी देखें, it's at the level of rectum. While the transverse vaginal septum can be anywhere from introitus to cervix. Again, this was my patient, and this picture I found on the internet. And there is the uterus over here, which has a very little hematometra. So this one is the imperforate hymen. I'm not sure if you can differentiate the bluish bulge, and this one is more flatter and pinkish. So for imperforate hymen, it's very easy to operate. Just give a cruciate incision and you can drain the hematocolpus. While for a transverse vaginal septum, it's a whole complicated surgery, and how to give incision and what to do next is whole set of skills. For vaginal agenesis, so it depends whether it's the lower 1/3 or the upper 1/3, upper part. So if the lower part is not present, it's mainly the pathology of the vaginal bulb or the sino-vaginal sinus. While if it's the upper part, it was coming from the Mullerian duct. So if normally, if the upper 2/3 is not, upper 1/3 is not present, it's normally associated with absence of uterus, as well as we have in MRK syndrome. So this is a case of vaginal agenesis, and I think you can appreciate this absence of vagina over here, and the obstruction is quite high as compared to the one I show you in previous picture. And you can see, I think you can appreciate this uterus and having hematometra here. Okay, so horizontal fusion, it could be partial or complete. It's the failure of union of the two uterine tubes. So there could be a whole long list of different type of anomalies. They may or may not be present with amenorrhea, because mostly they don't have the outflow obstructions, but and can be easily detected on 3D ultrasound. You can also detect it on 2D ultrasound and MRI as well, but it's a new modality, and would be cost effective as compared to MRI. So a 13-year-old presented with a cyclical lower abdominal pain, breast and pubic hair were developed, right? So this was a real-time case, and this was her MRI. And I hope you can appreciate the uterus here, the green line, and the small bulge in front. So this case was unilateral uterine horn, sorry, a single uterine horn on left side, while there's a complete failure of development of right side horn. And there's a small pouch which would be remnant, a part of the vagina that's formed on the upper part, but the lower part of the vagina was not developed in this case. And similarly in this picture, so this is the uterus above, and this is a small collection in what I suppose is a part of a vagina. So this is, again, the green part is the uterine horn and the vagina. And here you can see the ovary and the tube on the right side hanging along the wall of pelvis. And this was actually the unicornate uterus with vaginal agenesis. So if the uterus has a functional endometrium and with an obstruction, then only they present with primary amenorrhea. Otherwise, it's very difficult sometimes to differentiate these. And I hope my senior colleagues would agree with me that this one would be the most difficult case to take care of when there is no cervix. There is an endometrium, and you might see a part of vagina, but if the cervix is not there, then there's no point in keeping this uterus. Okay, this is another complicated form of uterine anomalies. We also need to take care of other structures whenever we see a Mullerian anomaly, because kidney develops along with the Mullerian duct. And see, in this case, there was no kidney present on this side. This is the same case. And we can see the scoliosis in this girl. Okay, now coming back to the algorithm. So if uterus is absent, get a karyotype. You might be surprised with 46XY, or you can have a 46XX, which is an MRKH. So both of these, how do they present? Almost at the same age, maybe 16, 17 years, maybe earlier, having complete secondary sexual characteristics, and with a normal height. So let's see how to differentiate between the two. We all know, I hope you all know that MRKH is a syndrome in which Mullerian agenesis takes place, where there's no uterus and upper part of vagina, and sometimes lower part is also absent. Hormonal levels would be normal, as they have both functional normal ovaries. And MRI, maybe the ultrasound and MRI can be the diagnostic things. While androgen insensitivity, on the other hand, is 46XY DSD, and previously known as testicular feminization or male pseudo-hermaphrodites. Breast development is normal, Tanner stage 5. There are very less or absent pubic and axillary hair, and external genitalia is absolutely female phenotype, while the gonads are testes, mostly with the features of testes at least, and can present in any of the path of testicular descent from abdominal cavity till the labia majora in these cases. So it can be androgen insensitivity could be complete or partial. It's very difficult to differentiate a complete androgen insensitivity from MRKH unless you get a karyotype, while partial can have pattern staging of any extreme. And again, the breast development and hirsutism you might see in partial androgen insensitivity. So these are the MRI of MRKH, in which there is no uterus. You can see normally the uterus is present here, right on the top of the bladder. So there's no uterus, but there the ovaries are well defined here. While in CAH, we can see the testis in the inguinal canal. So what are the similarities? As I already mentioned, that the stature would be same in CAIS. In androgen insensitivity, they might be taller. Breast would be fully developed. Genital were female phenotype. Uterus absent in both cases. Vagina is blind-ended, and FSH would be normal. But the differences would be pubic and axillary hair may be present. They are present in MRKH, while is absent in complete androgen insensitivity. Gonads would be can be seen on MRI and have typical features of ovary, while in CIH is mostly testicular features would be there. Location is intra-abdominal in case of MRKH, while androgen insensitivity, as I mentioned, it can be anywhere in the inguinal canal. And estradiol and testosterone is accordingly. So how to treat? we don't need to induce puberty because they are already having their hormones. In androgen insensitivity, because the end organ, what do you call, the receptors of androgens are not working properly. That's why, despite of having higher levels of testosterone, they develop Mullerian duct and external, they develop the external female genitalia. So for induction of menses, we cannot induce periods in them because they don't have uterus. Gonadectomy, of course, MRKH has a normal ovaries, we do not remove them. But for CAIS, if it's complete androgen insensitivity and the full-fledged testis are there, latest recommendation is to wait till the bones get full maturation. By the age of 30, you may consider removing it, because in this case, the risk of gonadoblastoma is quite less. For sexual life, we can have vaginal dilatation and sometimes vaginoplasty as well. For fertility issue, for MRKH, the latest trend or the latest hope is uterine transplant. Otherwise, we can offer adoption or surrogacy. But for androgen insensitivity, yes, adoption could be a possibility, but surrogacy would be quite questionable, because what to donate, ovum or the sperms in these cases. So it could be very tricky and should be considered with sensitivity of culture and religion. Psychosocial, yes, they both need psychosocial support, and both bone health would also be in consideration. But in these cases, I hope we all can understand that with the normal hormone levels, they do not need a special bone health. Okay, now coming to gonadal dysgenesis, we need to differentiate between the gonadal dysgenesis and the androgen insensitivities as well. Gonadal dysgenesis, the most common one is the Sawyer syndrome, is again a 46XY DSD, which lack the SRY genes on Y chromosome, and that's why the Mullerian duct develops. And it didn't suppress, but the gonads are actually dysgenetic, and that's why not producing testosterone. Breast development may or may not be present, and the uterus would be a rudimentary one. Then we have mixed gonadal dysgenesis, and is a whole list of chromosomal variation. They may or may not again have a uterus, or may not be having it. If there is a uterus, we can sometimes produce menstruation with cyclical hormone therapy. And I'm not sure about oocyte donation, and nobody has tried it on mixed DSDs so far as I know. The similarities would be the same, as the karyotype would be coming out to 46XY. Previously, I thought that it's the diagnosis, but now with the growing knowledge, we all know that it's just a direction towards a proper diagnosis, whether it's an anatomical thing, whether it's the receptor, or it's the deficiency. The genitalia would be female phenotype, and depending upon the, or maybe a certain variation of female phenotype. Location of gonad would be anywhere from in the path of descent of testis, and estradiol levels are low. So the differences would be there would be a well-developed breast in androgen insensitivity, while gonadal dysgenesis would have an underdeveloped breast, and pubic hair would be normal in gonadal dysgenesis. Gonads are having, predominant features of testis, while in gonadal dysgenesis, there would be streak or dysgenetic gonads. And uterus are absent in cases of androgen insensitivity, but may be present, or a very rudimentary small uterus can be seen in gonadal dysgenesis. FSH level would be normal in androgen insensitivity, but higher in dysgenesis, and testosterone level is accordingly as the presence of testicular tissues and hormones. So these are the pictures taken from the internet. So how to treat? We may not need to induce puberty in androgen insensitivity, but gonadal dysgenesis, yes, we need to help them in developing breast. Induction of period may or may not be present possible in gonadal dysgenesis. If there is a uterus and a little bit of functional endometrium, then we might be able to produce periods in these girls. Gonadectomy is highly recommended in gonadal dysgenesis due to the risk of gonadoblastomas, and because the risk of malignancy is very, very high in these cases. Sexual life would need vaginoplasty or vaginal dilatation. Fertility, adoption in our society and our culture so far. Bone health would be recommended for the gonadal dysgenesis. And of course, psychosocial support is needed in these cases. So just to end my presentation, clinical features should include, you should focus on cyclical abdominal pain when you're dealing with the primary amenorrhea cases, secondary sexual characters, abdominal mass, including the mass in the groin or in the inguinal canal, external genitalia, and vaginal size are important. On scanning, uterus is very important if it's there or not, and the appearance of gonads is also important. The hormonal profile that can lead us towards the diagnosis is FSH, of course, and along with this is testosterone and estradiol, and karyotype is the key feature to lead us to a certain diagnosis. For the Müllerian obstructions, imperforate hymen should be incised and the hematocolpus should be released. Similarly, in cases of transverse vaginal septums, cervical hypoplasia or agenesis is very difficult to treat. And vaginal dilatation has promising results for their sexual life. Otherwise, vaginoplasty can be considered. And surrogacy or ovum donation is a hope for fertility, preserving fertility in these girls, and uterine transplant for MRKH. I end my presentation here. I found these two very interesting articles. You can scan these QR codes and can read it out later. Thank you.
Thank you, Dr. Ifat, for a very interesting presentation. So in the interest of time, we can take one or two questions if you have any. Mic दे दें इधर.
Assalamu alaikum. All of these were excellent talks. I just have a couple of questions, but I'm not allowed to, so I'll just ask one or two. So my question is regarding CDGP and HH, hypogonadotropic hypogonadism. I'm not very experienced in treating both of these, but we do have a challenge when we come across these cases, because when a child is 14 or 15 years old, we don't know whether this is CDGP or HH. So what we do is that we give a trial of testosterone. And we give it for like how many for how many months do we give a trial of testosterone, and then for how many months do we wait for the appearance of puberty, if we think that this is CDGP, before labeling it as an HH, and do we repeat the cycle? So my question is from my pediatric endocrinology seniors and the other endocrinologist as well. And the other question, I have another question as well. Okay, एक-एक करके पूछूं, चलें ठीक है, सही है, पहले ये वाला question कर लेते
I
हैं.
think Dr. Aves is there, so he can comment on this.
Thank you for the question. CDGP और IHH में 14 to 18 years of age में problem होता है कि differentiate करने का, तो उसमें अगर constitutional delay of growth और puberty बहुत strongly suspected है, और अगर चाइल्ड को इतने ज़्यादा प्रॉब्लम्स नहीं है, साइको सोशल और इस तरह के बहुत ज़्यादा प्रॉब्लम नहीं, तो आप वेट कर सकते हैं. लेकिन अगर बहुत ज़्यादा है और बहुत परेशानी है फैमिली को, पेरेंट्स को, बच्चे को, तो फिर इंडक्शन ऑफ प्यूबर्टी की लो डोज से कर सकते हैं. तो 50 मिलीग्राम्स और 6 मंथ तक आप दे सकते हैं, ठीक है। उसके बाद आप उसको मॉनिटर करते हैं क्लिनिकली, ग्रोथ, सेक्सुअल मैच्योरेशन देखते हैं, और साइकिल कैन बी रिपीटेड, और 1 ईयर तक ऐसा करके देखा जा सकता है, ठीक है। तो लो डोज टेस्टोस्टेरॉन इंडक्शन के लिए, और अगर वो हाइपो नहीं होगा तो इंड्यूस हो जाएगी प्यूबर्टी, और वो प्रोग्रेस कर जाएगा इनटू प्यूबर्टल डेवलपमेंट। लेकिन आफ्टर 1 ईयर ऑफ एज जनरली मैंने जो लिटरेचर सर्च किया था, फिर उसके बाद अनलाइकली होता है कि वो हाइपो हो और सीडीजीपी ना हो।
Thank
तो
you so much.
cycle can be repeated or after 6 month trial of low dose testosterone.
Thank you so much, sir. That was very detailed answer. My next question is from Dr. Iffat. It is regarding the CAIS versus SWIA. So I wanted to know the waiting period for orchidectomy in CAIS patients. We know that the breast development is dependent on the aromatization of testosterone in CAIS. So we would like to wait for the puberty to complete in a child with CAIS before going for an orchidectomy. So how long can we wait till the risk of gonadoblastoma has increased substantially? Can we wait till 15 or even more than that before going for an orchidectomy in CAIS versus SWIA?
Okay, so there are contradictory literature reviews, and it says that you can wait up to 30 years of age when they have achieved their full strength of bones. But with this, you need to keep a very close observation on the gonads, because there is a risk of gonadoblastoma in this, although very low, very less, but still there is a risk, and you need to follow it through MRI. And still they don't know what to look on the MRI. So it's like in a phase of learning phase. Everybody is in a learning phase to see how to follow this, but at least you can wait till the attainment of puberty, complete attainment of puberty.
Rest assured that it is complete androgen insensitivity. Yes. If you are diagnosing it early, because if it is partial or incomplete, then you will have a lot of realization before, if they have decided to rear their child as a female. So you have to keep that thing in mind. Ideally, genetics is going to give you the answer if you can do it in the early phase. But yes, there is a combined decision. That sometimes the parents say, no, we want to take the decision at this point in time, and please remove the gonads, so that we will be on one side. And sometimes the children even say, but there is no definite recommendation. But if you are sure that this is complete androgen insensitivity and you are genetically proven, then I think you can wait. But otherwise, there is an effect of gonads, and the production of androgens would be there on the child. That's what I want. Mera question, Dr. Vaise, I do see lots of cases of thalassemia who are not achieving puberty. So they are also worried about their facial hair and the mustaches and the beard. And I don't know why, because even if you are giving testosterone, there is not much response on the facial hair and the mustaches. So is there any local application or something like that which we can offer to them? Sir,
Local application of what?
testosterone gel or
टेस्टोस्टेरॉन जेल का मेरा एक्सपीरियंस तो बहुत लिमिटेड सा है, और अवेलेबल था, लेकिन अब पता नहीं मिलता है कि नहीं मिलता टेस्टोस्टेरॉन जेल। तो हम तो यूजुअली इंजेक्शन यूज करते हैं, लेकिन थैलेसीमिया में मुझे ये समझ नहीं आया कि वो फेशियल हेयर, और आपने क्या कहा सवाल? जी जी जी। अच्छा, जो टेस्टोस्टेरॉन इंजेक्शन है ना, उसके बेसिकली जो जो डोज को मेंटेन करना होता है, बहुत इंपॉर्टेंट है कि वो किस रेंज में मेंटेन किया जाए। कि अब वो हमारे पास जैसे नॉर्मल इंडिविजुअल्स आते हैं, जब उनके टेस्टोस्टेरॉन करते हैं प्रैक्टिस में, तो देखते हैं कि अगर जैसे हमारे हॉस्पिटल की रेंज स्टार्ट होती है एडल्ट की 250 से 900 तक, लेकिन बहुत सारे इंडिविजुअल जो बिल्कुल नॉर्मली विरलाइज होते हैं, उनके 200 250 300 पे भी हो जाता है। लेकिन अब जो रिकमेंडेशन है या जो क्लिनिकल प्रैक्टिस है और जो कुछ थोड़ा सा एक्सपीरियंस है, उसमें तो यही नज़र आता है कि ऐसे लोगों की जो डोजेस होती हैं वो मिड नॉर्मल या अपर नॉर्मल रेंज में रखना चाहिए। जैसे हमने जब अपनी ट्रेनिंग के दौरान जो ऑब्जर्वरशिप की थी यूके में, तो उसमें तो वो यही कहते थे कि अपर लिमिट ऑफ नॉर्मल पे टेस्टोस्टेरोन को मेंटेन करना चाहिए पीक लेवल्स पे, और ट्रफ लेवल पे भी फॉलिंग लेवल जो होते हैं, जो इंजेक्टेबल टेस्टोस्टेरोन के हैं, वो भी मतलब नॉर्मल रेंज में आए। लेकिन जब हम कराते हैं ट्रफ लेवल्स तो वो बिल्कुल लो नॉर्मल से नीचे होते हैं। मे बी के डोजिंग की फ्रीक्वेंसी शायद इतनी नहीं है, या उसकी जो इंजेक्शन की डोज है वो अप्रोप्रिएट नहीं है। लेकिन अगर किया जाए उसको अप्रोप्रिएटली मैनेज, पहले पीक लेवल मेंटेन किया जाए, फिर उसके ट्रफ लेवल्स को फॉलो किया जाए, तो रिस्पॉन्स आने के चांसेस हैं। ट्रांसडर्मल जो जेल्स आते हैं वो फिजियोलॉजिकल लेवल ज़्यादा अच्छा मेंटेन करते हैं एज कम्पेयर टू इंजेक्शंस। लेकिन अवेलेबिलिटी का इशू है, लोकल एक्सपीरियंस का इशू है। बाकी और maybe our seniors can comment on it.
I think Dr.
I may respond to this question. आपका क्वेश्चन शायद ये था कि लोकल एप्लीकेशन और टेस्टोस्टेरोन जेल की तो ऑफिशियल हेयर आएंगे। ये ऐसा नहीं है। टेस्टिवा के नाम से एक जेल आई थी फॉर फ्यू इयर्स में, 1 or 2 years, वो फेल हो गई, नहीं चली। अच्छा देखें, वो चेस्ट पे लगाते थे, ये यूज्ड टू अप्लाई इन द मॉर्निंग चेस्ट, और इफेक्ट वाज सिस्टमिक, लोकल इफेक्ट नहीं था। So instead of injection, you could use this on upper part of chest every morning, daily dose. और local कोई ऐसी जेल नहीं है कि ये facial hair को grow करे, no.
Thank you. So let's move on to comments from our respected panelist. Dr. Tazeen.
आवाज आ रही? अरे जी, थैंक यू आयशा, बहुत अच्छा तुमने टॉपिक सेलेक्ट किए और बहुत अच्छे स्पीकर सेलेक्ट किए। मैं तो सिर्फ 2 पे कमेंट करूंगी, डॉक्टर उवैस पे वैसे ही बहुत सारे सवाल हो गए हैं, वो मेरी फील्ड से वैसे भी आउट है। तो एक तो ये कि जो तुम्हारा डिलेड प्यूबर्टी इन गर्ल्स था, के लिए, क्योंकि हमारे यहाँ जैसे ही डिलेड प्यूबर्टी की बच्ची कोई आती है तो हमारे यहाँ कुछ लोग सीधे सीओसीज बम्बार्ड कर देते हैं उसमें, जो कि बेइंतहा नेगेटिव है और उनकी समझ में ही नहीं आता। और खुसूसन अगर हाइपोगोनाडिज्म है तो फिर आपको जब आहिस्ता आहिस्ता एस्केलेशन करते हुए जाना है एस्ट्रोजन की, और जब प्रोजेस्टेरॉन देना है और आप चाह रहे हैं एस्ट्रोजन प्रोजेस्टेरॉन पे जाएं, तो मैं हमेशा उनको ये कहती हूँ कि एचआरटी पे जाएं, नॉट ऑन सीओसीज, बिकॉज सीओसीज तो उस वक्त दी जाएंगी ना जब आपको किसी चीज को सप्रेस करना है। एंडोजेनस हार्मोन आ रहा है, आप उसको सप्रेस करना चाहते हैं तो आप सीओसीज देंगे। जब ऑलरेडी कोई हार्मोन है ही नहीं मौजूद तो आपको हल्की चीज पे हाथ रखना है, जैसे एचआरटी पे, तो एचआरटी यूज करें। तो बहुत अच्छा तुमने प्यूबर्टी इंडक्शन बताया और आई होप के लड़कियों ने वो सीख लिया हो। प्राइमरी एमेनोरिया तो कूजे में बंद कर दिया दरिया को इस लड़की ने। मुझे तो कभी कोई कहे कि प्राइमरी एमेनोरिया इतनी सी देर में पढ़ा दो, मैं नहीं पढ़ा सकती। आई टेक मेनी क्लासेस टू फिनिश प्राइमरी एमेनोरिया बिकॉज इट्स अ वेरी बिग टॉपिक। और इसमें माशाल्लाह इफत मास्टर है, इन्होंने जल्दी कंप्लीट किया। जो सबसे इम्पोर्टेंट चीज इसमें जो है विड्रॉल ब्लीडिंग के लिए, क्योंकि अगर आप विड्रॉल ब्लीडिंग करा के, सबसे पहला टेस्ट हमारे यहाँ किया ही जाता है, तुम इफत ये करती हो कि विड्रॉल ब्लीडिंग करवाते हैं? अच्छा, हमारे यहाँ सबसे पहले ना विड्रॉल ब्लीडिंग कराई जाती है। और विड्रॉल ब्लीडिंग के लिए ये देखने के लिए कि एंडोमेट्रियम तैयार है या नहीं, तो विड्रॉल ब्लीडिंग इज नॉट अ नेगेटिव थिंग, आप करते हैं। एमेनोरिया की पेशेंट आती है तो प्रेगनेंसी टेस्ट एक्सक्लूड करते हैं, प्रेगनेंसी एक्सक्लूड करके वी गिव विड्रॉल ब्लीडिंग। तो उसमें आई वुड ऑलवेज से कि आप डाइड्रोजिस्ट्रॉन यूज कीजिए विड्रॉल ब्लीडिंग के लिए, एंड डोंट यूज नॉरेथिस्ट्रॉन, क्योंकि नॉरेथिस्ट्रॉन इज कन्वर्टेड इनटू बॉडी टू ईस्ट्रोजन, तो आपको ईस्ट्रोजन प्रोजेस्टेरॉन विड्रॉल इफेक्ट ज्यादा मिल जाएगा उससे। तो it's always better to use natural progesterone, progesterones, yes. कैरियोटाइपिंग के लिए एक बात मैं बताना चाह रही हूँ कि जब बार बार हम कैरियोटाइपिंग का जिक्र कर रहे हैं, सबसे इम्पोर्टेंट साइकोलॉजिकल एस्पेक्ट है इन बच्चियों का कि जब हम इनका प्राइमरी एमिनोरिया के साथ आती हैं और हम कैरियोटाइपिंग कराते हैं और अगर XY आ जाता है, तो चूंकि सारी जिंदगी वो बच्ची एज अ फीमेल पली है और आप उस पर एक बम फोड़ने जा रहे हैं कि तुम XY हो, तो खुदा के लिए बहुत ख्याल से उनको डिस्क्लोज कीजिए, एम्पैथी रखिए और वो पेशेंट को सीनियर मोस्ट आदमी देखे। ऐसी लड़की को पब्लिक सेक्टर में उमूमन ये होता है कि जूनियर तुम आए तो आ जाते हैं, हर एक बट के टोटों में डिवाइड करके। हमारे पब्लिक सेक्टर में हर कोई एक ही जगह पे आता है, तो उसमें अगर ऐसी कोई चीज है तो आप प्लीज अपने सीनियर के पास भेजें। एमेनोरियाज, प्राइमरी एमेनोरियाज बहुत सेंसिटिव टॉपिक है, बहुत मुश्किल टॉपिक है और बहुत सेंसिटिव टॉपिक है। तो सबसे मुश्किल मैंने इसी पे लिया था। एक तो ये कि नर्व एक्शन पोटेंशियल एक मुझे मुश्किल लगता था, एक प्राइमरी एमेनोरिया। तो फिर मैंने प्राइमरी एमेनोरिया को जूस बना के पी लिया, क्योंकि जब तक तुम उसको अच्छे से नहीं समझोगे, ये पूरी एंडोक्रिनोलॉजी है। अगर आपने एंडो नहीं समझी, मेडिसिन नहीं पढ़ी, एंडो नहीं समझी, तो आप प्राइमरी एमेनोरिया नहीं मैनेज कर सकते। तो इट इज बेटर टू रेफर दीज पेशेंट्स, these girls, to people who know their work, who know their job. तो I'm very thankful to आयशा जिसने इतना अच्छा प्रोग्राम सेट किया। लेकिन अगर वो SOGP का नाम भी और लोगो भी डाल देती तो हम बहुत खुश होते। नेक्स्ट टाइम प्लीज इसको आप खेलने की कोशिश कीजिएगा। थैंक यू एंड थैंक यू सामी फार्मा, जिन्होंने एकेडमिक पर्पस के लिए बहुत अच्छा मैदान सजाया। शुक्रिया।
Dr. Najmul Islam, sir.
क्या कहते हैं, आई मीन डॉक्टर साहबा ने तो बहुत अच्छा तीनों टॉक्स को वो करते हैं, लेकिन आई अच्छा basically because I'm an endocrinologist, so I will comment more on the first two talks, because the third talk जो डॉक्टर इरफत की थी वो थोड़ी सी मेरे लिए जरा मुश्किल थी to understand, but again as a physician I could understand all some extent. But I would like to comment on the first two talks. So पहला जो talk Aisha की थी, that was on delayed puberty in females. I mean, she has dealt with the topic nicely. The most good thing about her presentation was that she displayed the treatment aspect के पाकिस्तान में कौन-कौन सी preparations available है और किस तरह से उसको escalate करना है. That is very important for the people to know, because most people do not use that and they just jump on a higher dose directly, which is inappropriate. So I think congratulations to Aisha for presenting it in the nice way. Second जो है डॉक्टर ओवैस जो है, बाय द वे ये दोनों मेरे स्टूडेंट्स रह चुके हैं, मेरे अंडर ट्रेनिंग में दोनों। ओवैस जो है वो क्या कहते हैं, उसने इस टॉपिक को प्रेजेंट किया, बहुत नाइसली प्रेजेंट किया। लेकिन एक चीज मैं इसमें कहना चाहूंगा कि जो डोज एस्केलेशंस होती है उसको भी इसने हाईलाइट किया, लेकिन वेरी इंपॉर्टेंट टू, बिकॉज लोग जो है वो डोजेज बहुत फास्ट इंट्रोड्यूस करते हैं testosterone की in those whom they induce puberty. एक चीज और इसमें ऐड भी करना था कि once I was reviewing the literature on this topic of delayed puberty, I could see some case reports जिसके अंदर delayed puberty के अंदर even as late as 28 years of age people have entered spontaneous puberty. So हमारी teaching तो ये है कि 18 years के बाद जो है वो chances बहुत, but there is a remote possibility that somebody may enter puberty even as late as 28 years of age and not having idiopathic hypogonadotrophic hypogonadism. So that is something that I wanted to add to what he has presented nicely. And the third, Dr. Ifat ka jo tha wo, I mean, obviously we should know as the physicians that hormonal cause rule out करने के बाद अगर किसी को primary amenorrhea है, तो it should be referred to the gynecologist really for their workup. And obviously imaging तो हम already करा चुके होते हैं by that time. We have some idea what's happening there, but further management is your domain. So thank you, Dr. Ifat, for a nice presentation as well. I'll pass.
Dr. Saeed Meher, sir.
Thank you, Dr. Aisha, for the kind invitation. And I think so all the talks were very pertinent, very well presented. And this is the first time I'm seeing where our female audience are more than the male audience. And that's, I'm really happy to see that. पीछे बैठे हुए हैं. So it's something which is really a new trend and we'll appreciate it. This is a combined, because as Dr. Najam has said, there are multiple things in which there is always a joint ventures. You always need the referrals. So this is something which is always good. And this initiative of Dr. Aisha is always appreciated. So we started our journey together, Dr. Aisha and me. She was 1 year senior to me in fellowship in endocrinology, and I was 1 year junior to her. But still, because I know she sees more cases of a female delayed puberty and idiopathic than I see. This is something which is common in our setup. But whenever I see somebody with some female with delayed puberties and I stuck somewhere, always call her. Kiska ji kya karna hai? So still, I don't feel shy, but this is also call her, Keji, this is the case, and I need your experience because she has got more experience in females compared to male. As the male hypogonadism, very wonderful talk by the Oasis. The only thing which I will add in this, that majority of the cases we see with the delayed actually puberty in the boys is usually idiopathic, and they are usually obese. They've got weight. Only your empathetic counseling will be more than enough for them. Just wait for a few months, 6 months, and again, if you repeat the blood test or you counsel the family, I think so. This is more than suffix than going for a very expensive test and the MRIs and all these. But again, this is your decision. You are the best judge what to do in these. Again, the last talk of Dr. Ifat, really mesmerizing. And that actually reminded me of my final year MBBS when my teachers, I should definitely take her name, Professor Afta Munir. She was my teacher at the Liaquat Medical College, and she's an excellent teacher. She's not teaching right now, but she was my teacher. So really, I enjoyed the talk after a very long time of gynae and ops. And definitely, as Dr. Najam has already said, that there is always a mutual the referrals. What we can do the hormonal workup, but still if we see there is something would definitely will be referred to that particular person. Thank you very much again for your kind invitation.
Thank you.
1 मिनट में एक कमेंट देना चाहती हूँ. जो क्रिप्टोमेनोरिया की पेशेंट्स आती है ना, लड़कियां आती हैं हमारे पास, उनके लिए बड़ा क्वेश्चन है. कितने पेशेंट्स को हम सिर्फ इम्परफोरेट हाइमन समझ के खेलने लगते हैं, वो इम्परफोरेट हाइमन नहीं होती और वजाइनल सेप्टम होती हैं और अक्सर इतनी हाई होती हैं, वजाइनल एट्रीजिया होती हैं कि उनका फिर हिस्टेक्टमी पे हो जाती हैं. तो इसके लिए जैसा ख्याल रखिए, ब्लूइश कलरेशन नजर आ सकता है आपको वजाइनल सेप्टम में भी, लेकिन वो ब्लूइश कलरेशन मैनेज नहीं हो सकता आपसे. तो प्लीज 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 ऐसे पेशेंट को ज्यादा मजीद खेलने के बजाय आप आगे रेफर करें. इम्परफोरेट हाइमन अगर आपको आराम से बहुत बड़ा सा ब्लूइश बर्ड नजर आ रहा है तो उस पर काम कर लें, लेकिन अगर आपको बहुत हल्के से लग रहा है कि कुछ सेप्टम के अंदर से कुछ नीला नीला नजर आ रहा है, बहुत थोड़ा हाई होता है वो, तो उस पर जैसा ख्याल रखें, उस पर हाथ ना डालें. अगर डाल भी दें तो फिर रेफर कर दें फौरन, वो खतरनाक खेल है, उसकी बहुत एक्सटेंसिव सर्जरी होती है फिर.
Thank you. So now I would request Dr. Khadija to please come on stage and present a small token of appreciation to our speakers and panelists.